morning, everyone. I think we'll start. We'll make it very scientific, so there is no drama, I guess, today. So I think we are very excited because this year San Antonio, it was full of new data, and some of which practice changing, which we have seen as a reflection in the NCCN guidelines. So we're here together, all together, to learn from each other, to discuss these and see how we can apply it for best patient outcome in the clinic. We're very excited to have top-notch speakers from the region, from the Arab countries, Dr. Hikmat, Dr. Anwar, amazing experts from the UAE. Thank you all for coming, for supporting this. We believe in advancing cancer care under the umbrella of Emirates Oncology Society, and will continue to do so. Thank you so much. Prof. Hamid, if you want to give, maybe in your openings, in your session as well. So thank you so much. I think with further ado, we have Dr. 𝗦𝗫 also. She is chairperson of the symposium. I would like to hear her speech.
والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله. Good afternoon, everyone. First, I would like to congratulate Dr. 𝗦𝗫 𝗔𝗕𝗄𝗧 and Dr. 𝗦𝗫 for continuing doing Best of San Antonio on the way. So allow more people to attend and discuss the most important abstracts presented at San Antonio. I wish I'm with you, but unfortunately for a social reason, I couldn't come today. I wish you a fruitful meeting and enjoyable time. Thank you.
Thank you so much, Dr. 𝗦𝗫. And for those who don't know, Dr. 𝗦𝗫 did the Best of San Antonio, the 20th Best of San Antonio, just a few weeks ago. We are very proud of our collaboration. She's an inspiration to us, and will continue, inshallah, this on a yearly basis. So without any further ado, I would like to call for the first session. I would like to call my co-moderator, Dr. Nouri Benini, who is a dear friend of mine and expert medical oncologist, consultant medical oncologist at Tawam Hospital. Please join me in the stage. I'll introduce the first speaker, Dr. 𝗕 𝗫𝗏, who's also one of the expert medical oncologists in the field in the UAE, who's gonna talk about a very interesting abstract of HRT and breast cancer patient with BRCA1 and 2 mutation. Thank you.
Thank you very much, Dr. Aida, and thanks for the invite. It's such a pleasure to be here with such amazing colleagues, and especially for Professor 𝗕𝗄𝗧. Good morning to everyone who's joining virtually as well. So as Dr. Aida already hinted, this is a very important topic, something we don't talk about too much, but it's had a huge impact on our patients. And this abstract was presented by Dr. Joanne Kotsopoulos. She's a professor at the University of Toronto. So this is menopausal hormonal therapy and the risk of breast cancer in women with pathogenic variant in BRCA1 and BRCA2. Do I have the slider, please? Okay, so we would like to start off with this paper, which was presented or published rather a few years ago. This is a whole exome sequencing data from the UK Biobank. And this paper highlighted that patients who have genetic variants, certain genetic variants, they may have an impact on the human lifespan. So this paper pointed out that pathogenic variants of BRCA1 and BRCA2 patients have a significantly reduced lifespan. And we know that BRCA1 and BRCA2 mutations are associated with the increased risk of ovarian, breast, and fallopian tube cancers. So when we are talking about goals in BRCA carriers, our goal is not just to prevent occurrence of cancer, but also to reduce the overall mortality. And the best way, despite 30 years of progress, unfortunately, the best way to reduce the all-cause mortality is still oophorectomy in these patients. It is associated with a decrease in the risk of death by 64%. And but when you look at the other side of the coin, we know that in the general population, the same surgery increases the risk of death by 16 to 31%, and that is due to the effects on increasing chronic medical conditions, comorbidities, all those other things associated with early surgical menopause. So how do we balance this two? And if we are really going to make a strong case for prevention in high-risk breast cancer patients, we need to focus on mitigating the short and long-term adverse impacts of early surgical menopause and improve quality of life. And the best way to improve that is to offer HRT, or menopause hormonal therapy. But then there's a huge debate, as we all know, related to the HRT from the 20 years ago when we saw the results of Women Health Initiative study, which showed that there is an increased risk of breast cancer with the use of HRT, especially the combination. So there has been a huge hesitancy in providers in offering HRT to patients, not just with the BRCA mutation, of course. And then, of course, we have a very limited data on HRT and the BRCA carrier patients, because this is a very niche population, already have a very high risk. So we have very limited data of HRT in these group of patients, and it's an unmet need. So this calls for a very comprehensive analysis in the BRCA1 and 2 carriers that accounts for differences not in just their BRCA mutation type, but also the formulations of HRT, and hopefully have a longer follow-up. And this was a study question that was the hypothesis for the study, that is it safe for BRCA carriers to use hormone replacement therapy after oophorectomy with regards to their breast cancer risk. And also, they had further wanted to evaluate the relationship by gene mutation, because BRCA1 and BRCA2 can have a slightly different mechanism of causing breast cancer. And they also wanted to evaluate the relationship by the different formulations of HRT. So this was a very large collaborative, cooperative group study from Canada, but it was a global collaboration. They included patients with the BRCA1 and 2 pathogenic variants. Patients had no history of cancer or had not had bilateral mastectomies at the time of enrollment. There was a very detailed questionnaire that they were required to answer every year. So they must have had one follow-up. And the patients should have entered menopause by the time of at least their last follow-up. They allowed natural menopause as well, but majority of the patients had surgical menopause. So this was a study schema, and this is a match prospective analysis. So it's not a true randomized control trial, but as you can see, they really wanted to match for many important risk factors. For example, the gene type, the year of birth, the age at baseline, age at menopause, oophorectomy, age at oophorectomy. So all these points, they had matching of the eligible cohort, which was more than 3,000 patients. And I believe screened about 19,000 patients to get to this number. So in the end, they were able to identify 676 matched pairs, and one group received HRT and the other group had no HRT. And then they were followed and they were censored if they had breast cancer incidents, if at the time of the last follow-up, if they underwent bilateral mastectomy or death. So this is the baseline. Well, this is the detailed classification of the hormone replacement therapy. I won't go into too much detail because this is quite a lot of detail. They did a great job of clarifying the different formulations of HRT that were used, because in the Women Health Initiative study, there was a question about what type of estrogen. There was a class label on estrogen which was issued. So in this study, they clarified what type of HRT is to be used, and this all listed out here. Okay, so this is the characteristics of the study population, patient who had HRT versus no HRT. So as we discussed, they had matched most of the patients according to the age at the baseline, which was like 44 years. Majority of these patients had BRCA1 mutation, about 81%. Patients who did not go for HRT, they had a higher incidence of preventative mastectomy compared to those who took HRT. And age at bilateral oophorectomy was around 44 years. Mostly these were surgical, so these are surgical cases, 95% of the patients. And in the end, they also allowed a little bit of a crossover. So just to mimic a real prospective trial, about 62 patients in the no HRT arm later on went on to have HRT as well. And this is the result of this trial. So in the green is the patients who took HRT, and in the gray curve are the patients who did not have HRT. And you can see there was a clear decrease in the incidence of breast cancer among BRCA carriers who took HRT. So 24.5% risk of cumulative incidence compared to 43% in no HRT. So now looking at the breakdown of this analysis, so this is the adjusted hazard ratios for the combined BRCA1 and 2 group patients who had any HRT. They had a significant improvement. So there was an inverse relationship with HRT and the risk of breast cancer. It was statistically significant. And as you can see, majority of this benefit is being driven by the estrogen alone. So the hazard ratio is 0.37. The combined estrogen and progesterone actually did not have much effect, neither worse nor improvement. And then when you separate out by individual BRCA mutation 1 and 2, again, you see a similar pattern that any HRT use was associated with a decrease in the risk of breast cancer. And it was also primarily driven by the estrogen alone compared to the combination. And in the BRCA2 combination arm, we didn't have enough numbers to achieve statistical significance. This is again going into a little bit more nitty-gritty of the type of estrogen used. So this is the estrogen alone containing patients. So just to point out the highlights here, majority of the patients took transdermal estradiol, and we have a statistical significance in this group because it was a larger sample size as well. But they also had patients who took oral estradiol, oral conjugated estrogens, and synthetic estrogens. And when you look at the patients who had combination, so you don't see a huge difference in the hazard ratios, 0.9, 0.94 with no statistical significance. So again, pointing out that the combination did not have much impact one way or the other. Also to be mentioned, the conjugated estrogen with bezadoxifene was also used in this analysis. About 43 women used this. So this is a combination of course, the estrogen, but also a SERM, which is bezadoxifene. And it has agonist effects in the bone and antagonist effect in the breast and uterus. There was some data and study presented at San Antonio in DCIS patients who took DuaViv or DuaV, and they actually had a drop in their incidence of breast cancer. So this was another interesting HRT option minus the progestin. And in these patients, none of them developed breast cancer, but it's a small sample size of 43 patients. So in summary, in this group of patients who are forced into surgical menopause and suffer a lot of consequences of that, there was no adverse effect of HRT on BRCA breast cancer risk. Estrogen alone was associated with the most inverse relationship with the risk of breast cancer, irrespective of the route or the type. And the combination estrogen and progesterone had no increased risk. However, it must be noted that the use of HRT in this BRCA cohort was low, only about 37% of the potentially eligible patients. The limitation of the study is that in the subgroups, the numbers are small, and they did not stratify by the tumor receptor type. And we need a longer follow-up data on this study. And also, before I end, I want to just point out some of the outstanding knowledge gaps. So is concomitant hysterectomy warranted at the time of oophorectomy? Because if you can have hysterectomy, then you can avoid progesterone, and that was associated with a higher risk of breast cancer. So should we do both? And at the same time, BRCA mutations have not associated with a proven risk of endometrial cancer. So this is a question as clinicians we need to answer. Also, is 𝗕𝗏𝗃, which used with the doxepine as a SERM, can that be used to avoid using progesterone to prevent breast cancer? We saw some early encouraging data. And finally, the most unmet need is in the patients who have a diagnosis of breast cancer. Should we use HRT in these patients? Currently, the answer is no, but there are certain select population where it can be discussed as a shared decision making. So looking ahead, I think we need more evidence-based and personalized approaches to menopause management. And it's an important issue for our women with breast cancer. Thank you very much.
So much, Dr. Hassan. So we will actually keep the questions to the panel discussion. Thank you so much.
Oh, thank you.
Now I'd like to introduce my dear colleague and friend, Dr. 𝗕𝗏𝗁 𝗫𝗁 𝗫𝗍𝒂, who is one of the expert medical oncologists in the UAE and a consultant medical oncologist at 𝗕𝗏 Medical City. Please go ahead, Dr. 𝗕𝗏𝗁.
Assalamu alaikum, everyone. Thank you, Dr. Aida. Thank you, Dr. Hamid, for the invite, and the congratulations for the OS team and the organizer for implementing this session today. So my topic actually is very important topic to the oncology field in general, the oncofertility. I'm going to present the preferred study which was presented by Professor Lambertini in the San Antonio. It is talking about the fertility and ovarian function suppression preservation in premenopausal women with early breast cancer. So oncofertility is one of the most important topics that we are used to discuss with our patient before starting the chemotherapy for patients with perimenopausal. And it's very important in our area because most of our patients in the Middle East, they are early age or younger age in comparison to the Western countries. So we have different ways to do fertility preservation. We know that we have the cryopreservation for the oocyte or for the ovarian tissue. We have also the GnRH agonist injection that maintain the ovarian function all over the chemotherapy course. We have limited data to address these available strategies and what is the impact on survival using these strategies in patients with premenopausal patients undergoing chemotherapy. So counseling is very important and it's recommended. I think all of us doing it before starting the chemotherapy, especially for the new diagnosed early breast cancer. Again, the data is limited. So the preferred study is doing this. So it's simply assessing the fertility preservation and what its effect on the prognosis of the patient and what is the reason of refusal of this oncofertility or LHRH agonist administration. So it was done in Italy among around 23 cancer centers between 2012 and 2014. They included patients with stage 1 to 3 invasive breast cancer, premenopausal, up to age of 45, and they being candidate for either neoadjuvant or adjuvant chemotherapy. They excluded patients with stage 4 or prior exposure to chemo or radiation therapy or psychiatric disorder or an ability to give a written consent. So the primary objective of the preferred study is to investigate the need and choice of the available strategies of ovarian function and fertility preservation among premenopausal women with early breast cancer, in addition to the percentage of acceptance or refusal or the reason of refusal of this strategy. The secondary objective of the preferred study is to assess the safety of the controlled ovarian function, ovarian stimulation of oocyte cryopreservation, including the DFS and its effect on DFS and overall survival by using this strategy in patients under the age of 40 years. So they define subgroup according to predefined subgroup according to the hormonal status, positive or negative. They highlighted that the embryo cryopreservation it was not allowed in Italy. So this is the flow chart how they did it. So they collected the patients and then they subclassified them according to the age, less than 40 and from 40 to 50, 45. For the patient group with 41 to 45, they allowed them to get to preserve the ovarian function using the LHRH agonist. And the reason of refusal was if they refused, the reason of refusal was reported. However, for the patient with less than 40 years of age, so they counsel them, and if they have the desire to to preserve the fertility. So if it is if less than 2 weeks to chemotherapy, they can do the ovarian tissue cryopreservation. However, if it is more than 2 weeks or till we start the chemotherapy, they allow the ovarian stimulation and followed by oocyte cryopreservation. And if the patient refused, they again reported what is the reason of refusal. This is the patient characteristics and treatment characteristic. As you can see here, most of the patients being diagnosed recently between 21 and 24 years, 2024. And majority of them, about 42% of this population, actually they are childless. They don't have children. And you can see also here about the overall population, about 746, less than between 40 and 45, about 200 patients, while less than 40 years of age, about 500 plus a patient. When it comes to the hormonal receptor status, as we are seeing in the clinic, most of them are hormone receptor positive, 72%. And when it comes to chemotherapy, 50% of the patient population receive adjuvant, and the other 50% receive neoadjuvant chemotherapy, mostly anthracycline taxane-based chemotherapy. And here is the result of the study in patients between age of 40 and 45 years of age. About 75% have accepted to start to receive the 𝗕𝗫 agonist, and the reason for refusal of the other 25% of the population because of the completion of family planning. And as you can see here, if we subclassify them according to the hormone receptor status, there was little higher acceptance among population with hormone receptor positive in comparison to hormone receptor negative to receive the 𝗕𝗫 agonist. When it comes to the population of the child less than 40 years of age, as you can see here, about 1/4 of this group of patients, they did the cryopreservation, and about 90% of them received the GnRH analog agonist, as you can see here. And the reason of non-accepting or refusal of getting the cryopreservation or GnRH agonist was again family counseling. When it comes to the estrogen receptor positive or negative, there was no difference between these group of patients in the younger age, less than 40 years of age. So when it comes to the factor with acceptance of cryopreservation strategy for younger patient population, as you can see here, mainly the childless. So patients who didn't have a child or who don't have children, they preferred to do the cryopreservation. Also, the year of diagnosis between 2021 and 2024. Also, the lower grade breast cancer population, as you can see, the hazard ratio 1.8 for the grade 1 and grade 2. However, for hormone receptor status, BRCA status, and timing of chemotherapy or tumor or nodal size, it didn't differ, honestly, in terms of acceptance of the cryopreservation in this younger age population. When it comes to the key patient and treatment characteristics according to the oocyte cryopreservation use, as you can see here, again, the factors that affected this, whether the patient had ovarian cryopreservation or not. As you can see here, again, it's more significant according to the year of diagnosis, the more recent years between 21 and 24, and the childless status. However, the tumor size and nodal status didn't differ a lot. So we don't see any difference according to the hormone receptor status, the BRCA status, or timing of chemotherapy among this people. This is very important. What is the effect of getting ovarian cryopreservation on DFS and overall survival? Honestly, after adjusting the hazard ratio, there was no difference in DFS and OS in this population less than 40 years of age by getting the ovarian or the cryopreservation. As you can see here, the adjusted hazard ratio for DFS was 0.78, and for the overall survival, the adjusted hazard ratio was 0.53. What about, according to the hormonal status in this population, less than 40, and who did the ovarian cryopreservation? As you can see here, again, the adjusted hazard ratio didn't show any impact on both DFS and overall survival. The hazard ratio 0.79 and 0.27 for DFS and OS respectively. So in conclusion, this is a multi-center Italian study highlighting a very important topic that we are doing every day in the clinic for our patient, premenopausal patient with early breast cancer. There was a high acceptance rate to do a 𝗕𝗁 during the chemotherapy for the ovarian function preservation, 89% for the patient less than 40, and it was 75% for patients between 40 and 45. Out of them, 1/4 of the population less than 40 years of age accepted to undergo cryopreservation procedures. And main factors associated with the acceptance were the younger age, no prior children, more recent years of diagnosis, and the lower tumor grade. The controlled ovarian stimulation for oocyte cryopreservation didn't appear to negatively impact the prognosis in terms of DFS and overall survival. So this was the first study, a prospective study, to show us the evidence of improvement of the oncofertility counseling on patients without affecting the DFS or OS by using this cryopreservation or the 𝗕𝗁 agonist injection. I think this is the last slide, and thank you so much for your attention.
Thank you, Dr. Dalia. And our next speaker will be a recorded presentation by Dr. 𝗦𝗫 𝗫𝗁 from Jordan, and she'll be talking about elacestrant in combination with everolimus or abemaciclib in patients with ER-positive, HER2-negative, locally advanced or metastatic breast cancer. Phase 2 results from the ELEVATE and open-label umbrella study.
Couldn't join you in person, but at least I'm joining you virtually. Thank you, Dr. Aida, for the kind invitation and the organizing committee. EOS, great job you're doing. And at least I could join you virtually. It's a very exciting program, and my talk would be focusing on something that we all talking about, enhancing targeting the proper target in oncology. We're talking about overcoming endocrine resistance in metastatic setting. I could advance my slides. Sorry. Yeah. As my esteemed chairperson have told you, I'm discussing elacestrant, which is an oral SERD with agonist-antagonist activity in combination with a targeted agent, either mTOR inhibitor or CDK4/6 inhibitor in patients with metastatic breast cancer who have been exposed actually to some sort of treatment. This is a phase 2 trial focusing on improving our armamentarium of endocrine therapy. Why we are talking about elacestrant? It is among the earliest oral SERDs that has proven activity, by the way, both in ESR1 mutant and ESR1 wild type metastatic breast cancer. Indeed, the hazard ratio is 0.55, whether you are talking about comparison against fulvestrant or standard of care in ESR wild type or mutant metastatic breast cancer. But the approval is, as you all know, for ESR1 mutant breast cancer. I can understand because of the price. If it were not for the price, these oral SERDs should actually replace what we have currently of fulvestrant. So they look at the outcome in combination with targeted agents. As you can see here, the focus of the patient population are patients who have been treated with some endocrine therapy, no prior chemotherapy for metastatic breast cancer. They allowed up to 2 lines. Even fulvestrant was allowed. CDK4/6 inhibitors were allowed. Primary endocrine resistance, defined as less than a progression within 6 months of metastatic breast cancer treatment, were also allowed. This is safety efficacy phase 2 trial. Phase 1b to determine the proper dose, the safety, and phase 2 to determine the efficacy. The combination of elacestrant was used with a group of targeted agents. In phase 1b, they decided the dose. Phase 2, they decided the efficacy of that combination. ELECTRA trial focused on the combination of elacestrant with 𝗕𝗫 and they found that those in phase 1b. In phase 2, they examined the efficacy in patients with brain mets in ELECTRA phase 2 trial. We are focusing on ELEVATE phase 2, starting with elacestrant in combination, as you can see here, with Afinitor, an mTOR inhibitor. The patient population is typical with what you see in clinic. 70% of the patients had visceral disease, primary endocrine resistance in 20% of the patients, which is great, and 100% of the patients received CDK4/6 inhibitors. This is quite reassuring because this is your typical patient population these days. Most of us start with a combination with CDK4/6 inhibitor. And even 50% have received fulvestrant. And the reassuring news, a median progression-free survival of 8 months. Indeed, it is around what you expect in Bolero trial when we combined Afinitor with fulvestrant. We had a progression-free survival of 6 months, but that was not after CDK4/6 inhibitors. You are talking about a combination with an oral SERD after CDK4/6 inhibitors and having a median progression-free survival of 8 months. Quite reassuring for the activity. And what's interesting is that the activity was independent of ESR1 status as expected from elacestrant, number 1. Number 2, it has been demonstrated that combination of targeted treatments with endocrine therapy overcomes ESR1 mutation. And this is another testimony for this observation. It was also independent of PIK3CA mutation, a known mutation that could weaken the effect of Afinitor. Still, as you can see, or everolimus did have the same positive impact when combined with oral elacestrant. There was a disease control in 90% of the patients, or 80% of the patients, and the overall response rate, however, was modest. So do not expect your patient having significant disease burden to have shrinkage. It was only about 20%. Indeed, this is what's reassuring to put things into perspective. We had the median progression-free survival of 8 months along the same line of what we saw with another oral SERD that made headlines last month at San Antonio, giredestrant, when combined with everolimus, again, the same median progression-free survival of 9 to 10 months, reassuring of this activity. Elacestrant with everolimus, giredestrant with everolimus, you're expecting a median progression-free survival anywhere between 8 to 10 months. Among a patient population who had been treated with CDK4/6 inhibitors. No pain, no gain, but this is indeed a very tolerable combination. 6% had to stop the everolimus treatment, but otherwise, no bradycardia, which has been described with elacestrant earlier, or photopsia. And as you can see, grade 3 events, the dark blue are minimal apart from some anemia. Now focusing on the combination with 𝗕𝗫, and we know that 𝗕𝗫 after CDK4/6 inhibitors have some described activity. Just to keep in mind what it could do, despite the fact that it's been approved, it's only improvement of 2 months in progression-free survival. Let us see what it does when it's combined with elacestrant in this setting. Again, your patient population, 90% had visceral mets. Endocrine resistance has been described in 15% compared to 20% in the everolimus group, and fulvestrant has been used by 30% of the patient population. CDK4/6 inhibitor exposure was only 50%, not similar to the 100% we have seen with the everolimus, to put things into perspective. And as you can see here, again, a median progression-free survival of more than a year, which is quite remarkable. What's really important is that it was independent of prior exposure to fulvestrant, independent of primary endocrine resistance. So this combination does work. It does overcome endocrine resistance when you have a targeted agent CDK4/6 inhibitor combined with an oral SERD. Again, you have a disease control rate of 90% and a response rate in 25%, not too bad. How are we going to put things into perspective? Well, as you can see, another oral SERD, when combined with abemaciclib, indeed did not have that remarkable activity, but it's along the same line. You can see here, the combination did achieve improvement in progression-free survival, a bit less of what you see here, a testimony to the efficacy of what you see here. We're not comparing apples and oranges, but we need to see the comparable activity of a class agent. Definitely, combination with abemaciclib does achieve significant improvement in progression-free survival. Here, the hazard ratio is actually almost 50% reduction in that risk. And if you look at the activity of oral SERDs in the second-line setting, it's mostly along what you saw, single agent, 5 to 7 months, but goes up to around 1 year when you combine with a targeted agent, as you saw here. Again, no pain, no gain. Very nice safety profile, apart from neutropenia, not febrile neutropenia, but neutropenia, as expected, and nobody discontinued treatment, a testimony to the tolerability of 2 oral agents. And yes, it's not about the actual median progression-free survival, it's about the ability of targeted agents to improve the activity of endocrine therapy, overcoming endocrine resistance. Even you do not need to test for ESR1 mutation, despite the fact the subset of patients who received abemaciclib and elacestrant, we do not have the data for ESR1 mutation yet because the data is not mature, but it looks like it's quite promising based on a plethora of trials proving that this combination overcomes the need to test for ESR1 mutation. So definitely, elacestrant is a great oral SERD that can be combined with targeted agents to overcome endocrine resistance. And if it were not for the price, I would use it. I would use oral SERDs across the board rather than having intramuscular treatment for our patients. And with this, I conclude and thank you for listening.
Thank you, Dr. Sana, for the interesting really report of this trial. And I'm sure it will get a lot of discussion about it. And then our next speaker is our friend and eminent speaker from Kuwait Cancer Center, Dr. Anwar Nouri, from the breast unit in KCC. And we will be speaking about clinical and biomarker subgroup analysis of the EVERA breast cancer, a phase 3 trial of giredestrant plus everolimus in patients with estrogen receptor positive, HER2 negative advanced breast cancer, previously treated with CDK4/6 inhibitor.
Thank you. It's a pleasure to be in Dubai again. I was here last week and probably again next week, I don't know. And thank you for the invitation. And just to follow up on Dr. Sana, I'm in the process. Believe me, I am. I'm in the process to invest here. So I will take everything from UAE. So to follow up on Dr. Sana's talk, I have this talk, which is clinical and biomarker subgroup analysis of the EVERA trial, breast cancer, a phase 3 trial of giredestrant plus everolimus in patients with estrogen receptor positive HER2 negative advanced breast cancer previously treated with a CDK4/6 inhibitor. And I think this is an unmet need, and it's an important trial because, as we know, that these were the disclosures, that what to do after progression. So we know that CDK4/6 inhibitors are first-line standard of treatment for the past 10 years, but what to do after that, there's no the best answer. So giredestrant and everolimus target 2 signaling pathways, ER and PIK3CA, AKT/mTOR respectively, which are associated with endocrine therapy. And the EVERA breast cancer is the first phase 3 trial to demonstrate statistically significant and clinically meaningful improvement in the PFS with an all oral SERD Keep that in mind, it's an all oral SERD combination of 𝗔𝗕𝗓 and everolimus versus the standard of care of endocrine therapy plus everolimus in patients with luminal subtype breast cancer and post CDK4/6 inhibitors. So the PFS benefit with 𝗔𝗕𝗓 and everolimus was observed, and they showed that in the ESMO. And then the OS analysis was still immature, and the safety profile of this combination was manageable. And we'll go and see now the subgroup analysis of this trial. So this is a study which is as I mentioned, a global randomized open label phase 3 trial. And basically they had luminal subtype breast cancer, 1 to 3 lines of therapy in any setting. In the metastatic setting, 2 or less lines of endocrine therapy, no chemotherapy were allowed, and they had were allowed if they had progressive disease post CDK4/6 inhibitor in the adjuvant setting, which is something that is answering what we're doing in practice right now. And then they randomized them to receive either 𝗔𝗕𝗓 with everolimus or endocrine therapy with everolimus. And the endocrine therapy was either an AI, fulvestrant, or tamoxifen. 373 patients. And the primary endpoint was investigator PFS in the patients who had ESR1 mutation and in the population, intention to treat population. And they had stratification factors, which is looking at prior treatment with fulvestrant, either yes or no. ESR1 mutation, whether they had it or not, this is an important part. And site of disease, whether they had visceral or versus non-visceral. So these were the baseline characteristics of the patients, and they were well balanced on both sides, especially if you look at the ESR1 mutation, which was over half of the 50% of the patients, so over half. And if you look at also the PIK3CA pathway alteration, you can see that also it was divided well, balanced by both groups, whether they're on the 𝗔𝗕𝗓 or the standard of care. So this is the co-primary endpoints, which is the investigator PFS in the ESR1 mutation and in the intention to treat population. As you can see here, favoring the 𝗔𝗕𝗓 group with an improvement of median PFS from 5.4 to 9.9 with a hazard ratio of 0.3, and the intention to treat population, similar hazard ratio, similar improvement in the PFS with a hazard ratio of 0.56. If you look at the objective response rate and duration of response in the ESR mutation and intention to treat population, and in the patients without the ESR. And I think this is an important slide. So objective response rate in the ESR1 mutation, you can see a delta of 12%. In the intention to treat population, 12%. And the patients without the ESR detection, also you can see a delta between both groups of 11%. And you can see also in the group of the 𝗔𝗕𝗓, there's a CR where you don't see any CRs in the standard of care endocrine therapy. If you look at the median duration of response, similar in the ESR1 mutation, intention to treat population, and patients without ESR, the duration of response favoring the 𝗔𝗕𝗓. In terms of adverse events, we clearly see it here. The side effects were similarly balanced between both the groups. Even if you look at the adverse events with fatal outcomes, which were basically pneumonitis in both of the groups, or sepsis. There's one patient I know sepsis, a few patients had pneumonitis. They were consisting of 2.7%, which is 5 patients only. And then if you look now here in the PIK3CA mutation or alteration in the ESR1 population. So on the left side here, you can see that the alteration is detected. So there's an improvement of the PFS from 5.5 in the SOC to the 10.1 in the 𝗔𝗕𝗓 with a hazard ratio of 0.45. So favoring the 𝗔𝗕𝗓 group. And if you look at the right side where there is no alteration, you can see similar results with a similar hazard ratio. So it didn't matter whether they had an alteration or no. And if you look at the intention to treat population, whether they had an alteration in that pathway or no alteration, you can see similar results with an improvement of a median PFS, similar on both groups with similar hazard ratios. And if you look at also now the investigator PFS by PIK3CA alteration pathway status. So In the first part, you see all patients with the ESR1 mutation. So whether they had the PIK3CA mutation or alteration in the pathway, it favored the 𝗔𝗕𝗓. The second part in the middle is the patients with no ESR1 mutation. And again, whether they had a PIK3CA mutation or alteration in the pathway, you can see that there is a favoring in the 𝗔𝗕𝗓. And also, if you look at the intention 3 population, you see similar results. Now, when we look at the duration of prior CDK4/6 inhibitors, which is an important factor also for us, so less than 12 months or more than 12 months duration of being on that treatment. So they, on both sides, they are favoring the 𝗔𝗕𝗓 with very nice hazard ratios and improvement of the median PFS doubling between the standard of care and the 𝗔𝗕𝗓. And if you look at also in the intention treated population, the duration of CDK4/6 inhibitor, you see similar results, whether it is less than 12 months, more than 12 months, more in the ESR1 mutation group, but even in the intention treated population, you can see that. And this is the subgroup analysis, whether it's showing you whether it is less than 12 months, 12 months to 24 months, or more than 24 months. More pronounced in the ESR1 group, but also seen in the non-ESR1 group. And if you look at also the type of CDK4/6 inhibitor they were taking, again, it didn't really matter much. So they came to the conclusion that 𝗔𝗕𝗓, a next generation oral SERD, in combination with everolimus, showed statistically significant and clinically meaningful improvement in the PFS and versus the standard of care of endocrine therapy plus everolimus in patients with ER-positive, HER2-negative advanced breast cancer in the post-CDK4/6 inhibitor setting. The safety profile of 𝗔𝗕𝗓 plus everolimus was manageable with no unexpected findings. And in this analysis, in both the ESR1 and intention to treat population, the magnitude of clinical benefit was clinically meaningful and consistent regardless of PIK3CA mutation or alteration, duration of the CDK4/6 inhibitors, and the choice of the CDK4, whether it was palbo, ribo, or abemaciclib. So finally, 𝗔𝗕𝗓 plus everolimus was or may represent a new all-oral. And I think that is an important part, a standard of care treatment option in the post-CDK4/6 inhibitor setting for patients with ER-positive, HER2-negative advanced breast cancer. Thank you.
Thank you so much, Dr. Anwar, for this excellent presentation. We'll move on to the next speaker, Dr. 𝗦𝗫 𝗕𝗿, who is the chair of oncology at Dubai Hospital and the board member of the Emirates Oncology Society. Welcome, Dr. 𝗦𝗫. Please go ahead.
Morning, Assalamu alaikum. I heard a lot of oral today, so I'll be talking about something IV now. So we've got 3 drivers. When patients are progressing, we got to inhibit the mTOR pathway, the PIK3 pathway, the ESR. We can all do it in this study. So it's a kitchen sink approach. So this is an updated results of the Victoria-1 trial. You saw the results, amazing results in ESMO 2025. So this is a pan inhibitor. It's called a multi-target PIK3, AKT, mTOR inhibitor. So all together, and they have given it with fulvestrant, which is, can work for against the ESR as well. So this is given in combination with palbociclib. So you're continuing the CDK4 inhibitor. This is the patients who have all received prior CDK4 inhibitors. So this is a second-line study. So this is by Barbara. So this is the background, as I mentioned already. So this, you saw the results of this study, and it did show actually this gedatolisib, which is a potent PAM inhibitor. It improved the patient's outcomes who are PIK3 wild type. So we don't have the data for the ESR from this study. So combination of GEDA, I should call it GEDA, plus palbo plus fulvestrant, median progression-free survival was 9.3 months. I think we did not see this before. Hazard ratio 0.24. I think amazing, versus a combination of GEDA plus fulvestrant, with the progression-free survival was 7.4 months. And then the areas of interest, obviously, are the side effects, hyperglycemia that we need to think about, and stomatitis, and that's where they're going to look at those results now. So these were the results. If you look at triplet versus a doublet, and this is in terms of prior therapy. So they have divided into more than 6 months, more than 12 months, more than 18 months, more than, it looks mirror image, I think, doesn't matter when you use it. So that's, I think that's quite nice to see. More than 6 months, 9.9 versus 1.9 months. Now the problem here is the control arm looks quite weak here. Maybe the control arms is not performing as good. It's about 2 months in all subgroups. What about versus a doublet? We also see the signal here. The magnitude of benefit again looks similar, but obviously numbers are less. So we're reaching 7.6 months with a doublet. So it has an efficacy. What about different subgroups in terms of bone metastasis, no bone metastasis, triplet versus doublet? We see similar results, so benefit in all subgroup of patients. So it could be used in any of those patients who may be progressing on CDK4/6 inhibitors. Stomatitis, I think that's a challenge. So you see stomatitis is up to 70%. I think it was a problem in the initial study, but they gave this swish wash to everybody and it improved. So grade 1 and grade 2 and grade 3 numbers here. So majority of the patient actually they said they have the grade 1 stomatitis, but you have to use this mouthwash. And when this happens, it happens early on. So I think you have to, if you have to use the drug, you have to use it proactively early on to try and reduce the stomatitis. Time to improvement, what they're saying that it can actually improve quite quickly if you have grade 2 and 3 event, if you manage it properly. Glucose levels, that's interesting as well. Obviously, they did not randomize patients who had type 1 diabetes. If you had type 2 diabetes, your HbA1c should be well controlled. We actually did not see much significant rise in glucose level with this particular drug. I don't know whether we are managing the better or the patient selection. So these are the all grades toxicities here. But overall, it seems quite similar between all 3 arms. Quality of life was better as per the study, although it is IV weekly, 3 weeks on, 1 week off. But despite this, patients were feeling better, which is interesting as well. So the question is whether we will be bringing our patient cycle line to our infusion center every week for this. So these were the conclusion of the study. I think they concluded that this is the first study which showed a very significant improvement, which is both statistical and clinical in progression-free survival with this PAM inhibitor. And this was seen irrespective of the prior duration of therapy. You don't need to check ESR mutation. You could use an all comers, but you have to focus on managing stomatitis. But important thing was hyperglycemia was not a major problem. Thank you very much.
Speaker, we have Dr. 𝗦𝗕 𝗫𝗏, who is the Chief Medical Officer and Consultant Medical Oncologist at NMC Royal Hospital in Sharjah. Welcome, Dr. 𝗦𝗕.
Thank you. Thank you, Dr. Aida. Thank you so much. So I'll be presenting for you today some updated data that was already presented. So this is the 𝗦𝗫 plus fulvestrant in POK3 mutated hormone-responsive HER2 negative disease after CDK4 inhibitor progression. They called it the EPIC-B5, and it's a randomized trial that was presented by Dr. De Laurentiis. And as a background, as we all know, that standard of care as first-line metastatic hormone-responsive disease would be CDK4 inhibitors with a combination of other AI, sometimes even tamoxifen with zoledronic acid, with the gosiraline. So, but then again, we see this resistance within 6 months, 1 year, even after. So the 𝗦𝗫 is an alpha PYK inhibitor that showed in the previous trials with the SOLAR trial that there's a benefit of the addition of 𝗦𝗫 with fulvestrant, which improvement in progression-free survival, but did not show really a good overall survival significance. And they included in the SOLAR trial that the patients who had prior CDK4 inhibitor treatment. The number was limited due to the availability at that time of the CDK4 inhibitor use. So the EPIC-B5 study is comparing alpelisib plus fulvestrant versus placebo plus fulvestrant in hormone-responsive advanced breast cancer HER2 negative with the 𝗕𝗏 mutation that had all progressed. So all these patients has received previously CDK4 inhibitor plus an AI that was conducted in patients prior treatment to confirm efficacy in this category of patients. And this is the data that was presented here. It was in 2024. Later on, the cutoff point was May 2025, and this is the updated information that we have. As a reminder of the randomization, these are all patients postmenopausal who has the mutation, who progressed or relapsed on a CDK4 inhibitor with an AI. At least they allowed in this trial, they allowed chemotherapy as adjuvant or even the metastatic setting, and they were randomized 1-to-1 alpelisib plus fulvestrant versus placebo plus fulvestrant, and the primary endpoint was progression-free survival. The secondary endpoint were overall survival, response rate, as well as clinical benefit. Now, if you look at the baseline, the characteristics are very similar. You only see that the patients who received more chemotherapy in the metastatic setting were in the standard air placebo with fulvestrant. This category seemed they received more chemotherapy than the studied arm. Now, in the cutoff point of October 2024, you see there's a significant in the progression-free survival with 5.4 months versus 2.8, and with a hazard ratio of 0.52. The response was significantly seen in this category as well. It was 23% versus only 4% with the placebo fulvestrant arm, and this was significant at that time, and it was being standard of care and started to be used and approved. Now, when they looked into overall survival at that time, there was a trend for the overall survival, but it was not only numerical, and there was no significance at the time, but it was not reached. But when and they showed us, as we all know, the safety profile of these medications is mainly the hyperglycemia and rash. Now, I can tell you it's a headache, the hyperglycemia with your patients, especially diabetic patients. We all now have the experience. They come to you. Their problem is no more the cancer, is actually the blood sugar. So they argue with you the blood sugar, the management, and how up and down, how they suffer at home, and their focus on cancer actually decreased. So this is something that it's really, to be honest, is disturbing in the clinic. Now, when you look at the interruption of the medication, the dose reductions, it's very obvious that with the use of the alpelisib, we have significant reduction of the dose interruptions. If you look at the discontinuation, you mentioned that 80% alpelisib fulvestrant and 86% with the placebo. Numbers are not clear here. If you look at it more, that actually the drug discontinuation with the study arm was related because of the side effects, rather than the placebo arms because of the progression of the disease and change of the medication. And that's why we have to be very careful of the numbers that we see. Now, with the updated data with the cutoff point of May 25, here we started to see a significant overall survival, a barely significant overall survival with 29 months versus 23 months for the alpelisib arm versus the placebo. And at the summary and conclusion, just to follow up on the SOLAR trial, that the EPIC-B5 met its objective, primary objective, was showing a statistically significant and clinically meaningful improvement progression-free survival for patients with hormone-responsive advanced breast cancer harboring the 𝗕𝗏 mutation and that have progressed after CDK4 and an AI. And at the primary analysis, there was a positive trend of overall survival, but with this trial, we have a significant overall survival benefit. If there's no safety alarms established in this trial, and the data confirm the trials of the SOLAR, will support the use of alpelisib plus fulvestrant as treatment effective in this category of patients. Thank you again for your invitation.
Great first session. We covered a lot about, hormone therapy resistance and then oral SERDs. And I think there is a big debate around like using combinations, single therapy. So can I call the speakers to join us on the stage for the panel discussion? Dr. Hassan, Dr. Adalia, Dr. Hamad, Dr. Anwar. And we have Dr. Abdurrahman is here as well. Yes, please. Okay, so let's start with questions from the audience. Dr. Saeed has a question. Can we provide him with a mic, please?
Thank you very much. Good morning, and thank you very much to all the presenters. Very, very nice session. So we have now repeatedly seen post-CDK4/6 inhibitors, several strategies, mainly oral SERDs in combination with Afinitor, or we have seen in combination with CDK4/6 inhibitor in case of imlunestrant, and also in case of gedileucel, we have seen triplets as well. And all of them looks like that they are giving you a PFS, as Dr. Sana also mentioned, of around, I don't know, somewhere between 8 to 14 months roughly. So which strategy should we use? And they look like that all of them, they are independent of ESR1 mutation, PIK3CA mutation. So in case of the patient who's already been treated with first-line CDK4/6 inhibitor and the endocrine therapy, and imagine that endocrine therapy is also fulvestrant. So, which one would you go? You go with a doublet, you go with a triplet. If you go with a doublet, we go with Afinitor, or you go with something else. Any takers is okay.
I think basically on the clinical scenario that you have, and whichever is fitting the trial, then probably maybe it could be the best choice. I don't think we have a clear answer like right this second, but the trial I presented shows really the practice that what we're having right now. Basically progression on adjuvant, they included those, which is a good step in the trial, because we do have those patients who progress on adjuvant CDK4/6 inhibitors, and what do? We don't have a clear answer for those. This trial shows the answer. And also that all patients in the metastatic setting should, to be included, they had to have CDK4/6 inhibitors. So no alteration, no mTOR inhibitors were allowed. So in that trial also. So there is a lot of inclusion criteria in the EVERA, which is really representing what we're doing in this in the patients today. A majority of them, at least, is covering, with the exception of some patients. If you're, for example, if somebody you're giving inavolisib based on the inavo, then yes, they wouldn't be there, but most of them would be included.
I think, Dr.
Can I
thank you
quickly
so much.
comment from a distance?
Of course.
So go ahead, Dr. Sana.
They're all very interesting. Again, good morning to you all, and really missing being among you, but glad virtually at least. A very smart question, but I would always answer all these are really goldies. So what you look at, you have to look at something that you can afford, you have access to. If oral SERDs were actually affordable, I would definitely choose the oral SERDs. Which one you choose, I don't think you're going to go wrong with anyone you choose. All of them have proven activity. Companies don't like that, but indeed, for me, I would go to whatever affordable, whatever accessible. Now, the combination, it makes sense to choose something with non-cross resistance. EVERA and ELEVATE did actually demonstrate the activity of everolimus. Again, one thing I missed actually pointing out, the dose of everolimus they used is 7.5 milligram. What we use in everyday practice is not the 10 milligram. And indeed, it has been demonstrated that 7.5 milligram drug exposure is similar to the 10, something we don't talk about in our meetings because everolimus is an old drug. But actually, it's coming to life with the oral SERDs. So I would be choosing a non-cross resistant combination after CDK4/6 inhibitors, using everolimus because it's tolerable, rather than going for more toxic combinations. We know how to handle toxicity. It's oral, and they're both oral. So you have to choose non-cross resistant, affordable, accessible combination. And I would highlight that 7.5 milligram, which is like 10 alternating with 5, probably would do that, is as good as 10 daily. Makes it more affordable, less toxic for your patients.
Thank you so much for the great discussion. Actually, I think the EVER trial design is very smart design. I think they included, what Dr. already Anwar mentioned, the clinical, relevance, what we see also regardless of the ESR, regardless of the PIK3CA. I mean, it just makes life easy. I think Dr. Saeed mentioned maybe the drug will be available in UAE in the summer. So I think for me, it's going to be the drug to go to. I mean, it's oral, it's easy. You don't have to think much about all these complex pathways. So let's see. But I think I'll be excited. The Victoria is under design, but again, this is IV formulation. Let's see when it comes, if it is going to also make a difference. I need to give you the mic. I know you cannot resist.
Good morning. Salam alaikum. 1 minute, but he gave me the phone. He is the chairman.
Phone, mic.
Maybe I have a question. So thank you very much. I mean, for the last few years, we've been talking about biomarkers-driven therapy. And now we're going back and treating everybody similar. Is that what's going to happen? Because we're talking about emergent mutations. If you develop ESR mutation, you may act on it. If you have PIK3, you do that. But now we're talking about drugs which can work for everybody. So how are we going to do that in the clinic tomorrow?
The real question is that do we actually need to test for these things?
Yes.
If we're gonna switch anyway, and it's working anyways in both entities like PI3K or regardless of ESR1 mutation.
With the presentation of Dr. Sana, it's really obvious. I mean, whether the patient have a mutation or not, whether they had before CDK4/6 or not, they derive all a good outcome. So why should we just do the test just for a prognostic factor or just to direct treatment? Now we have to,
also probably to sequence later. That's why probably that's the only thing I can think of.
If you do the combination to begin with, it's very difficult to have more options down the line because you have already exhausted in the first line. So unless you want to do elacestrant plus everolimus and then to go to PI3K, this is something that I'm, still exploring. Still, we don't have solid data for. But Dr. Hassan, go ahead.
No,
okay,
same
Dr. Ghazali is waving there.
No,
okay.
that's okay. I just want to mention more to come. We have SERENA-4 coming up also, which will be first line, SERDs. So it may also reshuffle what we are doing in first line. So that's important. And my other question, what do we think now of elacestrant single agent? We have this data. So obviously combination should be the way to go if you want a higher efficacy. Any place we may still think of single agent SERDs.
I think the problem will arise again soon because these trials are happening so fast. Is that Dr. Saeed Rafi, what he mentioned is that, the triplets, and if triplets become standard first line, then what do we do with these trials and these results? And then we have to do more trials to see what's the best option after those. But at least, again, when I look at the EVERA trial, I think it represents most of the practice right now.
The only reason we are testing ESR1 mutation these days because in the US, the FDA approval for oral SERDs is still for ESR1 mutation, driven, I believe, by more financial reasons rather than scientific reasons. The activity has been demonstrated in both ESR1 mutant and ESR1 wild type, and it has been across the board demonstrated if you combine an agent, that mutation is no longer relevant. So it's purely driven by the bureaucracy of approvals and financial reasons. The best reason is get them to be affordable, and they will replace definitely independent of ESR1 mutation. And one more thing, let me remind you, 10 years ago, I discussed the ESR1 mutation. It's a dynamic mutation. You test for it this month, you find it. You test for it in 2 months, you might not find it. So it's a very dynamic mutation. And I was surprised to actually take it as guidance for FDA approval. I believe it's all financially driven. So let's wait and see, especially for the ESR1 mutation. I don't think it's biologically at this stage relevant with these combinations.
Doctor, a very, very good point. Actually, I was going to raise the issue of the SERENA-6. How does this integrate into the practice? Dr. Aida maybe can enlighten us. I had discussion with her about this. So I think, as you mentioned, the ESR1 is, it's a dynamic. Are we going to act on the molecular progression rather than anatomical or imaging progression? This is something actually ongoing with the SERENA-6 which seems to be like gaining some momentum in some of the breast cancer experts globally. And there was a very nice review actually a few days ago published. It tackled this issue very nicely, and I will encourage everyone to have a look at this. So I would like to hear from you. What do you guys think? I mean, it's very interesting discussion.
Well, I just wanted to make a comment on the previous point here. I think the combination with CDK4/6 of oral SERD is also quite promising, right? I think the PFS data we saw was a little better than with compared to everolimus. Again, this is cross trial, but I think the debate is still on whether we use it with a CDK4/6 like we did in EMBER-3, or also what we saw in elacestrant and abemaciclib. I think CDK4/6 combination remain very active. Yeah.
Yeah, I mean, it's a debatable field. I mean, I'm still trying to wrap my head around the whole data and put things into perspective. By the end of the day, we are in the clinic. I mean, we can talk about all of these combinations, but what we actually gonna tell the patient, how we gonna do it in the clinic? It's case by case situation. It's very complicated. Whether I want to do it from the first line setting based on biomarker, which is also very challenging from a logistical standpoint, doing like these kind of mutations every few months. Who's going to cover for it, how feasible it is, what's the turnaround time, am I really going to change to a very expensive medication, whereas I can maybe do it later? Am I going to lose patient late in the second line setting if I did not do it from the first line setting? So these are all big questions that we need to answer. I think all of these data are very valid. I think it's going to come in practice, whether we like it or not. I just think that we need to find the appropriate path for the patient. But having all of these also options for the patient is a plus, because by the end of the day, we are treating a patient with different background, different clinical status, different psychosocial status. So all of these options being available, it makes it easier on us as a physician as well.
I think that one of the issues is we are used to have an increment or a new drug once every 2 to 3 years. And now within the last 2-3 years, we have, instead of one, we have 3-4 drugs coming in the same setting with almost the same indication, with some differences regarding the use of mutation for directed treatment. But in the same time, they are overlapping a lot with the indication, and that makes us more confused. And we are going one step forward in the sense of directed or treatment directed by mutation and by molecular testing. And now we are stepping back because it seems that to be at least some combination are good for everybody. So probably the next future or near future will make the things more clear for us to choose the best pathway of our patient in the clinic, because we are now from one drug to a pathway where we have 3, 4, 5 drugs coming in the same indication with different combination. I think it's exciting time.
We would like to hear your opinion as well.
Thanks, Dr. Aida. I was hoping that this discussion would be at the end of the day after presenting all data. But looking at the San Antonio presentations and even the last ESMO, 3 issues. Lots of those studies did not allow crossover when patient really progressed, and this is not the real way that we practice in medicine. That if you allow crossover, lots of those data would be different. That's number one. Understanding, of course, that some of those studies were registry studies, and those registry studies for approval usually won't allow crossover. But yet, this is not the real world, the kind of the clinical practice. That's number one. Number two, lots of those studies did not really address sequencing. So if you don't use this drug in the first line, you can use it the second and third line. That's the issue. Third, if you use any of those third and single agent compared to the standard of care, you would see that in both arms, in the first 2 to 3 months, everybody would drop off, which means that when we allow the combination of those SERD plus everolimus or SERD plus the abemaciclib, those curves at least start to build early on, and you don't see that drop off. So the final question would be how much of money we can afford to present those, and should we do it preemptively when you recognize that this patient have a ESR mutation, switch before they develop radiological or a clinical progression, or wait until you see it. And I guess the question would be, I mean, these are the three things. I'm not sure we need to rush into change our practice. I think we just need to wait a little bit to absorb what we already have seen. And I guess lots of these things really would need a real world evidence, a real world data before we implement it into clinical practice.
I totally agree. I second that. I was going to say the same thing. I wouldn't rush and do the change. Actually, many experts even coming here and discussed, they are not, following that route. Remember, there is no survival advantage and there is no crossover allowed. So there's many pitfalls for the study to be a positive study on PFS. So I would, 𝗕𝗏, of course. So I would be careful exactly what Dr. Hikmat mentioned.
Okay, just to change from the subject of the ESR mutation, we'll go to Dr. Shahryar for the very interesting topic. And okay, you presented the case, the topic for BRCA population. So, but what about the general population? And what about the breast post-adjuvant treatment patient on remission? So, can we extend this indication or not? This is the question that we'll have to answer in the clinic tomorrow.
Thank you for the question. I think we have to be careful when we are selecting the population. So we now know in the high-risk group, there is safety data with the use of HRT. And again, we need a little bit longer follow-up for this. But when we're talking about patients who have a diagnosis of cancer already, then there is at least three groups there. The one is a very low-risk group, which has pre-cancerous changes like atypical ductal hyperplasia and things like that, where you could have a discussion because they are sort of high risk, but not truly cancers. Second group is the patient who have ERPR negative breast cancer and they have been remission for say 5 years. And now you want to discuss whether adding HRT would help with their quality of life and symptoms. So that's a second intermediate group. And then the third is the highest risk group where they have ERPR positive breast cancer. And in that group, I think generally we still don't offer, there's no clear safety data to use HRT, but even it came up in the discussion that even in those patients who are having severe menopausal symptoms, you could, as a shared decision with the patient, discuss use of HRT. So I think the bigger message is that the pendulum has shifted from no HRT, which is in the general population, to now HRT. There is no black label warning anymore. I think there were issues with the way the black label definition was applied. It was across all estrogens, whereas in the WHI study, it was conjugated equine estrogens which were used in combination with progestin. So I think there is now more acceptance of offering HRT, at least to the general population and high risk. But for the patients with known cancer, we have to be very careful and selective.
What about the dose and the duration?
Right. So there are different formulations available for HRT. Usually, so we were talking about patients who had surgical menopause. So that is around age of 40 for BRCA1 and 45 for BRCA2 patient when they have the surgery. So they should be offered at least till they reach their natural age of menopause. And then there is a discussion whether you want to continue it or not. So that 10-year of period is the most critical where you can offer. So in the study, on average, they were on HRT for 5 to 6 years. And the formulations, it's most of them use transdermal estradiol, and it is titrated to adjust to their symptoms. So somebody having vasomotor symptoms, somebody could just benefit from 25 mcg change every 2 to 3 days versus 50. So that's more of our clinical judgment.
I don't use the combination. I mean, the older data tell us that the combination is really what the risk of breast cancer, not the estrogen alone. As long as the uterus is okay.
Dr. Adalia, you presented an interesting study, but it was an Italian study. We are in another part of the world with different population, younger, and the fertility is all-time an issue for us in the daily practice. Do you see any differences between the outcome of this presentation and our population here?
Okay, I think the only difference that we have more patients that are younger at presentation. This is very important trial and concept to our population in the Middle East, because as I mentioned, we have more patients in the premenopausal status. So it is a very important topic to be discussed and counsel the patient before and her husband before starting the chemotherapy. And it's very important to differentiate between two important subjects, that the fertility and the ovarian function, because this is the two different issues. So the patient to be able to get pregnant, this is how we counsel the patient. Very important to preserve the ova or to preserve the ovarian tissue. This is very important. But getting the 𝗕𝗫 agonist, this is important for patients more than 40 or less than 40 if they want to keep the ovarian function and to avoid the toxicity of ovarian function suppression. So in general, it's important and essential before starting the chemotherapy.
Question is to the panel and the access in the country here. Let's talk about in the Middle East or in Kuwait. How is the access to fertility centers? In my institution, we have a fertility center. We have certain access, but the problem, the access is limited. It's not free. It's still not accessible to all patients on an, let us say, for free or at least, and it's expensive. So do we refer all our patients to the fertility center prior to treatment or not, or what's happening in different institutions?
Unfortunately, I mean, the truth is that most of the insurance does not cover for it, the fertility preservation. So we do refer the patient. We have the same access to Corniche Hospital, for example. New technique, state-of-art technique. You can do it within 7 days or even less sometimes. But the unfortunate truth is that it's not accessible to many. And most of these patients will end up not doing anything. I will offer them GnRH based on this. I mean, have I seen patients regain their ovarian function after chemotherapy and got pregnant? I mean, lucky for them it did, but I think we need to collaborate more with charities, maybe with access program to make it available. This is very important. I mean, they go through life-changing therapy, and the least we can do is support them from this aspect. Thank you.
In Kuwait, it's available if you're a citizen only. So if you're an expat, it's not available except in the private sector. Private sector, it costs around 2000 dinars, كم درهم? 20 to 25,000. And even for citizen, it's limited. So if you have 2 children or more, then you cannot, even if, they will not. Even if you have 2 daughters, no sons, they still will not allow it. No exception at all. In 10 years I've worked there, not once I have seen an exception. So 1 child, no child, they'll do it. 2 or more, regardless of the sex of the child, they will not do it, even if you're a citizen.
Yes. And if I may, so I think it's not only about the access, about when they come to you to the clinic. So they're coming to you with the anxiety of cancer, and then you're offering fertility. They're confused. So they will see that they need more counseling. So by the time the family, they need to discuss it. You need someone to counsel them. Where's the benefit, not the benefit, focus on fertility, focus on treatment of cancer. So this is not only about the access, their decision to preserve fertility sometimes is difficult. And the patient at the beginning, when she sees that she needs to go and treat cancer because she wants to save her life, she's not focused on the fertility. After you finish the treatment, she would tell you, doctor, can I get now pregnant? Well, we discussed that before. But at that time, her focus was mainly about her life. So I think we have also a gap in the psychology and the counseling, how we can reach these patients before reaching the therapy. And this is, I don't find in my clinic, and even I tried multiple places to refer them to someone who can counsel them. It's really deficient.
Actually, that's why in our clinic, we implement very important part that we included the coordinator. So after the shock stage and from the physician, we discuss with the patient and her husband about the fertility and how we can preserve it. After going out of the clinic, we have a very good team, coordinating team that set again before starting the chemotherapy, and they discuss again all the toxicity and including the fertility and how we can preserve it. So I think, yeah, I agree with you. It's very important to avoid or to make it, to give it more time to discuss the fertility issue.
A quick comment, this issue with fertility or oncofertility, lately, we started to talk about it almost a decade ago, but lately, over the past couple of years, young patients come to the clinic and ask you proactively about this. It's amazing these days how many patients come to clinic well informed that there is a possibility. And indeed, we set aside a long time, and they want to hear from you as oncologists. They don't want the psychiatrist, they want reassurance from you as oncologists. It is doable, what data is there, and they go through the details. It's becoming a proactive question from the patient as compared to years ago when we were discussing, and it was a surprising question from us as oncologists. Now the patients come after the discussion. I don't know how about it, how do you see it in your clinics, but young patients, especially those who are younger than 40, they approach us wanting help and direction.
I think within Dubai Health, we do have fertility center. We routinely refer all our patients to the fertility center at the Hospital. Access can be a problem for some patients. I think there's some regulation with regards to if you're married or not married as well. So that there's some regulations, but the access is better than what it was 5 years ago. Definitely, we see more access now than what we had 5 years, and there are many private hospitals as well. Price varies between the centers, but we've seen even patients who have LHRH analogs, they actually get pregnant as well later. So they preserve. So at least you offer that if they can't afford the more expensive procedure.
I think this can go on forever, so we have to end it. So we start the next session. Thank you so much to everyone.
Thank you so much, Dr. Aida, and the expert, for the very exciting discussion. And we'll move now to the next session. We are on time, so we'll try to keep it on time, inshallah. I would like to welcome my co-moderator, Dr. 𝗦𝗔𝗕𝗖𝗦, who doesn't really need much introduction, consultant oncologist at Mediclinic Hospital, and he is EOS General Secretary. And the next session will be highlighting advancing targeted endocrine and AI therapies. It's my pleasure to welcome my dear friend, Dr. 𝗦𝗫 who's a consultant oncologist at King Hussein. He's a recipient of the King Hussein Award for Lifetime Achievement, and he joined KHCC in 2004, and he has extensive experience in breast cancer research. Welcome, Doctor. It's a pleasure to have you with us today.
Assalamu alaikum. Thank you so much. Thanks for the invitation. It's really a pleasure to be with you among the friends and the colleagues. So my duty today is to address a study which I will present the data as presented, not necessarily would we agree on the conclusion. So this is the study, and it's the HER2 𝗫𝗫𝗀05. It's a randomized double-blind phase 3 study of tucatinib versus placebo in combination with trastuzumab and pertuzumab as a maintenance therapy for HER2-positive metastatic breast cancer. And this is the Erika Hamilton from Nashville, who presented the data at the San Antonio. So just to give you a backup on this study, this is the current standard of care nowadays in the first line setting to treat HER2-positive metastatic breast cancer is an induction chemotherapy with a taxane, docetaxel or paclitaxel, in combination with dual anti-HER2, trastuzumab and bertuzumab, followed by a maintenance therapy with both the trastuzumab and bertuzumab. However, lots of us would see that lots of those patients would eventually experience a disease progression, and the question is what to do with this. Well, this is also a continuation of a previous study, which was registered and published in New England back in 5 years ago. And this is the tucatinib, trastuzumab, and capecitabine for HER2-positive metastatic breast cancer. As you see here, the study was about the start of tucatinib in addition to capecitabine and trastuzumab to treat those patients after they failed the first line. And obviously, back then, 5 years ago, this is the study at clear advantage in the progression-free survival, adding tucatinib to Herceptin and the capecitabine compared to a placebo. This is a BFS of 7.8 versus 5.6, and this also an overall survival advantage. So if you wait until you have a disease progression, then you have the option of starting tucatinib plus the capecitabine at the time of disease progression. Well, the current study is it's not to wait until you develop disease progression, is to start tucatinib maintenance after you achieve a maximum response with induction taxane initially. So this is the phase 3 HER2 𝗦𝗫-05 trial was initiated to investigate the efficacy and safety of adding tucatinib to a combination with trastuzumab and bertuzumab as a first-line maintenance therapy in patients with HER2-positive breast cancer. So this is the key eligibility criteria. So HER2 need to be confirmed at a central office, and those patients that should have no evidence of progression following 4 to 8 cycles of a combination of a taxane, trastuzumab, and bertuzumab, ECOG performance status of 0 to 1, and no or asymptomatic brain metastasis. And those patients were randomized into a tucatinib, an oral drug, 300 milligram orally BID along all days, once every 21 days, plus obviously the combination treatment versus the placebo. And this is the primary endpoint, the BFS, and the patient obviously were also stratified according to whether the metastatic breast cancer was a de novo versus recurrent, whether the hormone receptor positive versus negative, and the presence of absence of brain metastasis. So they started with a close to 325 patients in each arm, and just because not each and every patient would develop a stable disease, so they drop off the 176 patients in that tucatinib group versus 133 patients in the placebo group. And this is just some features of the patient characteristics. You would see here that 50% of the patients were hormone receptor positive, and just a small fraction, 10 to 12% of those patients had a stable brain metastasis, and the 2/3 of the patients had de novo metastatic breast cancer, 2/3 of those patients. If you look at the primary endpoint, which is the investigator-assessed BFS, as you clearly hear in the blue curve, those who received the tucatinib, the blackish one, the placebo, as you see here, the advantage is close to 25 months versus 16 months, a delta of 8.6 months in favor of tucatinib, an oral drug in this case, and this is a clear benefit with a very significant p-value. And this is the BFS and both a group, the hormone receptor positive. As you see here, the advantage is even better. The delta here is 12.3 months, which is a 24.9 compared to 12.6 months. And however, the difference in between the tucatinib and the placebo was less significant when you talk about hormone receptor positive patients. So the difference really was in favor starting this drug in hormone receptor negative. As you see here, the delta 12.3 compared to a delta of 6.9 in the hormone receptor positive patient. The other secondary endpoint, which is the blinded, the independent, the monitoring, the classification, as you see here, again, the delta was at 12.9 months in advantage of the tucatinib versus placebo. This is another key secondary endpoint, which is the overall survival. As is here, the curves are separating nicely. The median survival was not reached. However, it is hoped that with the more time, those curves would continue to separate to give us an advantage in survival. This is the safety summary. Nothing much between the two groups except lots of the GI symptomatology. As you see here, diarrhea, nausea, and the change in liver enzymes. Lots of those, the side effects. However, very few were grade 3, and lots of those side effects were manageable, and they can be dealt with easily without much of a problem. So to conclude, the 𝗕𝗏-𝗫𝗏05 stated that the addition of tucatinib to first-line maintenance therapy with the trastuzumab and bertuzumab demonstrated a statistically significant and clinically meaningful BFS benefit in patients with HER2-positive metastatic breast cancer that translated to a 36% reduction in the risk of disease progression or death. The median BFS, as I showed you, 25 months versus 16 months, and 8.6 monthly difference. And the benefit was observed across all patient subgroups. However, much more significant in hormone receptor negative patients compared to hormone receptor positive ones. And the preliminary overall survival data suggests a positive trend in favor of tucatinib. However, we need just to observe with the more follow-up. So the tucatinib, trastuzumab, and bertuzumab combination showed a manageable safety profile with diarrhea, nausea, and elevated transaminases, mostly at low grade, being the most common adverse event. However, the question remains, should we add tucatinib to the maintenance treatment before we have the disease progression, or wait until you have a disease progression and you can add tucatinib along with capecitabine and trastuzumab, as we already have seen in the study published 5 years ago in New England? So that's the question. Should we rush doing it in the maintenance before you see progression, or wait until you witness that disease progression and you add the tucatinib to the maintenance treatment? So that's the question. This is really where the study was performed. And this is the official publication of the study the same day that was presented at San Antonio in December of last year, just a month ago. With this, I'll stop here. And just because I'm heading to the airport immediately after discussion, after this study, so if you have any question, I can't take it now because I have to leave. Thank you so much.
Yes, maybe I can go ahead. Thank you. So very valid point at the end. And I want to ask you, did they mention the percentage of progressor who went on to tucatinib? But do we have that percentage on the control arm?
Yeah, actually less than 50% of the patient, if I showed you on the slide, the 325 patients were screened. The one that went into tucatinib was 175. So close to 50% of the patient went on.
Okay. And then he's leaving. Comment on the ER positive versus negative. We know in the neratinib extended adjuvant, it was the other way around. Any speculation?
Yes. Well, we don't know why. I mean, I guess just probably if you had more patients, you look into it more carefully, you have these things. But if you have to apply these things, it's apparently among the hormone receptor and negative. But I guess my own take on this is not to rush into tucatinib and to add it. If I have the choice, then I would wait until disease progression. I would add tucatinib to capecitabine and trastuzumab. because you probably would save you 50% of the patient would not need it to start with.
And if we start with TDXD, where would we end with that? No,
That's the whole story nowadays with breast cancer. It's really as complicated as it can get actually, and as expensive as it can get. Thank you so much. Thank you.
Okay, so the next speaker is online, and that is Professor 𝗦𝗔𝗕𝗖𝗦, is the professor and head of Division of Hematology and Oncology, Director of Breast Cancer Center of Excellence at the American University of Beirut. Professor 𝗦𝗔𝗕𝗖𝗦 is going to talk about central nervous system outcome from phase 3 PATINA trial.
Good morning, everyone. Do you see my screen?
Yes, we can. We can
Okay,
see.
very good.
You need to share your screen, Professor 𝗦𝗕𝗖𝗦.
I thought I did. You don't see it now?
Not yet.
Zoom. Share. You see it now?
Not yet. No, we cannot see your screen. But can you put it on the full screen mode, please?
Okay. I don't know what is this here. Zoom. Zoom. It is share. It says share. It's
You can see
sharing.
your screen, but you need to put it in the presentation mode.
Now, okay.
Not yet quite. There we go. Yes. Yes.
Okay, very good. Thank you. Good morning, everyone. Sabah al-khair. Sorry, also I could not join you. Okay, I miss you, all of you. Okay, but I see you on the screen. Good morning. I will present to you the abstract that was presented by Dr. Aro Metzger, CNS outcomes from the phase 3 PATINA trial. These are the disclosures of the author. As an introduction, we know that up to 50% of patients with HER2 positive metastatic breast cancer will develop brain metastasis during the course of their disease. Routine screening is not standard as per guidelines, although many of us do it, especially if there is an indication, but routine is not yet standard. Several anti-HER2 therapies have shown activities in active brain metastasis, but there is no clear evidence they reduce CNS metastasis. In the Cleopatra, the authors note that the incidence of CNS metastasis as first site of disease was 13.7% versus 12.6% without the pertuzumab. Now, the preclinical data show that palbociclib may have some CNS activity. So in this PATINA trial, the authors here looked at timing and progression of CNS disease. This is a reminder, the PATINA trial, patients with HER2 positive disease, they were induced, they had the induction chemotherapy, and then after 6 to 8 cycles of treatment that included trastuzumab, pertuzumab, most of them did get both. The patients were randomized to get maintenance therapy, either the standard when they are, of course, hormone receptor positive, standard trastuzumab, pertuzumab with endocrine therapy, or adding palbociclib to this combination. And the primary outcome was progression-free survival, assessed by the investigator, secondary outcomes, in addition to the overall survival, and the response rates included the incidence of CNS metastasis. This is also a reminder of the results. The PATINA trial gave an excellent median progression-free survival of 44+ months versus 29 months for patients who did not get the palbociclib. Hazard ratio 0.74, and interestingly, at 5 years, you have 43% of patients versus 33% only surviving at 5 years. Very good results. This is a reminder of the baseline characteristics. Note here that CNS baseline was in around 4% of the patients. Most patients had visceral disease, about 72-73% of patients had visceral disease, and 52 to 57 patients had de novo disease. Now, these are the results of this presentation at San Antonio. We see here the cumulative incidence of CNS progression or death of all randomized patients. We see that at 12 months, 24 months, and 36 months, there are less CNS progressions or death. At 3 years, 36 months, only 13.8% had CNS progression of death, compared to 20.4% in the group who did not get palbociclib. And the patients who did not have CNS at baseline, again, we see lesser cumulative incidence of CNS progression or death, and at 3 years, 13% versus 19% of the patients, which is very good result. So the conclusions of the trial, that the addition of palbociclib to anti-HER2 and endocrine therapy was associated with a lower incidence of CNS metastasis. And in patients without baseline CNS disease, this is important, the cumulative incidence of CNS progression or death was 13% only for palbo, while it was 19% with the control. So it tells us here that the addition of the palbo has gave this result of decreasing the incidence of CNS incidence and progression. So this is the conclusion: may delay or prevent CNS involvement in hormone receptor positive, HER2 positive metastatic breast cancer. Of course, we will say we need further validation in subsequent studies. These are the acknowledgements of patients and investigators. And I would like to add this slide, if you allow me. This is a non-San Antonio breast cancer slide, like the options in 2026 now for first-line management of patients with HER2 positive metastatic breast cancer. Really, it is now crowded. We have a lot of options. The standard remains Cleopatra or Peruse study. We use docetaxel, Herceptin, Perjeta, or paclitaxel, trastuzumab, pertuzumab. I think it remains good for older patients, frail patients with comorbidities, etc. We could still use it. Now we have the 3 trials: the PATINA trial, the DESTINY-Breast09, and the HER2-CLIMB-05 that we just heard presented by Dr. Hekmat. Here, all the patients did have induction chemotherapy, followed by, as I said here, trastuzumab, pertuzumab with or without palbo. Well, I think definitely this study is good for patients with hormone receptor positive. We add to them palbociclib with endocrine therapy. Now, DESTINY-Breast09, starting out with TDXD and pertuzumab, and continuing, of course, compared with THP, we saw significant improvement, median progression-free survival. But of course, we have more toxicity. I think it remains an important option when there is high disease load, visceral disease, CNS disease, or you have a short disease-free interval recurrent. Also, patients with mutated PIK3CA had the highest benefit. With the 𝗕𝗿𝗀, this is a good option. Start with chemotherapy and maintain with tucatinib. As we heard now, the gain in patients with ER negative is much better than ER positive. So probably maybe we'll use it more patients with ER negative and also de novo. I think around 70% of the patients had the de novo disease here also. Now we have 3 trials, very important to tell us whether we could do induction T-DXd pertuzumab and then follow it with trastuzumab pertuzumab. We have the INAVO 122 that added inavolisib in the maintenance phase. And we also have the HEREDERA trial that added giredestrant in the maintenance phase endocrine therapy for patients with hormone receptor positive disease. And with that, I thank you for your kind attention.
Thank you very much. Excellent presentation, Professor Al-Saghir. So if you can, please stay with us online. So we're going to have a discussion. So with that, it's my absolute pleasure to introduce Dr. 𝗕𝗏 𝗔𝗕𝗖𝗦, our dear friend and colleague, consultant medical oncologist at American Hospital. Dr. 𝗔𝗕𝗖𝗦 is going to discuss multimodal artificial intelligence model integrating with the image, clinical, and molecular data, predicting the early and late recurrence in TAILOR-X trial.
Good morning. Thanks, Dr. Saeed. Thanks, Prof. Hamid, Dr. Aid, and the whole EOS committee for inviting me. It never stops generating data from TAILOR-X trial being presented decades ago. And almost every ASCO or San Antonio Joseph Sparano comes with something about the trial, which is amazing. I found it. So this is now about artificial intelligence. So it's a multimodal integrating image, clinical findings, and genomic data or molecular data, how we predict early and late recurrence in TAILOR-X trial. So Joseph Sparano and his team who presented this. So this is his disclosures. So the background, I think everybody knows Oncotype very well in hormone receptor positive HER2 negative breast cancer, that it has both predictive and prognostic value. So it can tell us the risk of recurrence, distant recurrence in particular, but also whether the patient will benefit from chemotherapy or not in the hormone receptor positive HER2 negative, node negative breast cancer. So the TAILOR-X was primarily designed to address the uncertain group in the mid-range 11 to 25, whether they benefit from adding chemotherapy or endocrine therapy is enough, but also to validate or to confirm that those with low risk endocrine therapy is enough. And results are well known for, as I said, for many, many years now, that adjuvant endocrine therapy is non-inferior for chemotherapy and endocrine therapy in about more than 2/3 of the patients for those with 21 gene recurrence score 11 to 25. However, there is that, especially the women 50 years old or younger, they benefit from chemotherapy despite they are in the mid-range, but with variable clinical and pathological features. So the question being addressed many times before in other scenarios and in other data, like RS-CLIN, for example, integrating the clinical pathological features to have like more precise or more tweaking, more fine-tuning the benefit and the magnitude, whether it's worth it or not. Now, the objective of the trial was to develop a diagnostic test with better distant recurrence prognostication than the Oncotype on its own from the TAILOR-X trial. So they used primarily, it's a little bit complicated. I was there actually in the room when Joseph Sparano presented the data. It takes time to understand it. So basically, they brought the paraffin blocks, the genomic data, and they digitalized the hematolene and xylene or H&E, hematolene and eosine. Anyway, H&E images from the pathology lab, and they digitalize them. And they try to fuse all these data, and they come with some modeling. So the statistical analysis, they did something, as I said, clinical data, molecular data, they call it M+, because they used Oncotype in addition to others, like Predict, and I'll show you later, they did kind of more than 21 genes. And also the bathomic imaging of the slides themselves. And then they did the model training and validation, for whether that's better than using each of these on its own. And they come with something called C-index, the concordance between the pathological, molecular, and the bathomic, where you include also the digital. So these are the more than 10,000 patients were enrolled. In TAILORx, they found 78% the paraffin blocks are still available. 64% they have the H&E slides where they can digitalize them. And then that's in the training and cross-validation. And then in the whole out validation, 43% of cases they did the genomic, the whole transcriptome, and only 37% they can use their data in the validation. So, they found actually the between training and validation set, there wasn't really much of a difference in multiple variables like the age, postmenopausal, tumor size, BR positive, and low clinical, but there was some statistically significant, but not clinically really that different or marginal difference in high grade and low grade. That was in training and validation set. Even by excluding or including some variables, there was no much of a difference. So anyway, this is, I think, the main slide to show how they developed this. So they took the slides, they do the digitalization, and they come to an image at the end there, and they fuse it with the clinical data, which is primarily tumor size, menopausal, stats, age, and grade, and also the molecular. But that's what I meant by M+. They use not only Oncotype DX, but also some other gene sets were tested for M+. So M only Oncotype, M+, adding like EndoPredict and some other genomic testing. And then eventually they come up with the either divide them into high risk or low risk by incorporating all these data. And they found actually very good in the training model set, for example, they found for overall distant recurrence at 15 years, the ICM+, which means imaging and clinical data and expanded or molecular profiling, is the best predictor. But also CM only using the clinical and molecular is also good. You can see that they are statistically significant differences. Yearly, ICM+ and CM+ again are the best predictor than clinical alone or molecular alone. And even for late distant recurrence, more than 5 years, the ICM+. So you need also to include here that imaging. And this is the multivariate analysis. Again, the concept or the test stands positive even for this multivariate analysis in the training. And they applied it on those patients who were treated according to Oncotype DX result. And they found interesting data. Actually, even in those we think that they are low risk, 0 to 10, 7.2% they are actually high risk according to this model. And if you go into the middle, 11 to 25 treated only with endocrine therapy, 13.8% are high risk. And obviously, understandably, if you go to the high risk group, only 43% they are actually high risk according to this model. So there is a lot of work needs to be done or to take into account when you interpret Oncotype DX data. This is now the validation test. After the training, they did the validation set. Again, the data stands the same almost. So if you look at the overall distant recurrence, early distant recurrence, or late distant recurrence, if you use the clinical and molecular or clinical molecular imaging, that gives you better, and that stands for the multivariate analysis as well. And that applied this again in the validation test. They came with the same results that even in the low risk group, there is a small percentage who they derive benefit or they consider as high risk. But also on the other hand side, even those we consider them as high risk in the Oncotype, they're not equally high risk. Some of them are much higher risk than others. So the conclusion that training and cross-validation set the C model, which is clinical features, yes, it provides, as we do now, we know that, for example, node positive, high-grade, large tumor, it provides us some prognostic information. If you add the molecular, but here 42 gene, not 21 gene, including the oncotype and BCI and EndoPredict, that also adds to more stratification for early, particularly for early distant recurrence. If you add the I model, the digitalization of the images, then it strengthened the prognostic stratification, especially for late recurrences. And the ICM Plus model is the strongest prognostic performance, particularly for overall and late distant recurrences. Provides statistically significant and clinically relevant prognostication, and exhibited stronger performance than CM Plus. So, and that stands true for the validation set. When they validated this model, they found that ICM Plus, which is imaging, clinical and molecular models, both of them are, they have the superior prognostic value. Both ICM Plus and CM Plus models outperform the actual Oncotype DX, which I think we know that Oncotype is as good as it can be, but we still need more kind of tailoring or, and these are their work. They have other presentations, or they had other presentation at San Antonio, and they wanted to show their team and also their acknowledgement. And with this, I will stop here and say thank you very much.
Thank you so much indeed, Dr. Fathi. And with that, it's my pleasure to introduce Professor Peter Fasching, who is very well known in this region. Professor Fasching is Associate Professor of Gynecology and Obstetric and Gynecology Translational Medicine, University Hospital in London in Germany. Professor Fasching is going to talk about 𝗨𝗨 clinical trial. Thank you.
Thank you very much. Good morning. It's a pleasure to talk about the 𝗨𝗨 study, which was presented in San Antonio by Aditya Bardia. It's also a pleasure because the study was conducted by a trio, which I'm part of and director, and also NSABP. So Aditya Bardia did an excellent job in presenting this data that actually gives a very good perspective in what adjuvant endocrine treatment could be looking like in the future. We don't have to acknowledge that every time we're seeing a trial in the adjuvant setting for a large group of patients being hormone receptor positive, HER2 negative, that this might change the therapy landscape in a drastic way, and also in a way that we have learned in the past, as shown here in the ATTACK trial, was presented in San Antonio in the year 2002, December 2002, and it was 2025, where the next time, and the study is positive, we know that, a big improvement in the only endocrine treatment has been introduced in the treatment of hormone receptor positive HER2 negative breast cancer patients. A few years ago, the CDK4/6 inhibitors were introduced in the adjuvant setting, reducing the recurrence rate by about 25 to 33%, a quarter to a third of the recurrences can be avoided. And also, we recently learned from monarchE study that overall survival was statistically significant, improved with a hazard ratio of 0.84. NATALEE trial in that context is still pending. So we've been learning about the SERDs over the last 10 years. The oral SERDs are much more bioavailable. We know that the fulvestrant has been introduced in the adjuvant or in the metastatic setting in the year 2005 at a dose of 250 milligrams. It took another 10 years almost to find the right dose with 500 milligrams. And then one single adjuvant trial was started, but never accomplished, never finished. It was discontinued due to lack of funding and published some 6 or 7 years ago, of course, not being powered to show a difference between the aromatase inhibitor arm and the aromatase inhibitor plus fulvestrant arm. So this study now with the orally much more bioavailable SERDs, degrading the estrogen receptor, but also blocking
the ligand-dependent effect on the estrogen receptor is closing a scientific gap after a long time of waiting, because we know that the fulvestrant as a intramuscular SERD has been approved for more than 2 decades. The giredestrant, which was used in the lidERA study, has been well established in preclinical experiments as being very effective, even in comparison to other SERDs, has been tested in the neoadjuvant setting against the aromatase inhibitor and also against the tamoxifen, has shown superior reduction in Ki-67 in the 𝗕𝗿𝗀 trial, and therefore there's a very good rationale in designing a study and in testing the giredestrant in the adjuvant setting. The study that was designed looks at patients at an increased risk of recurrence, actually very similar inclusion criteria compared to NATALEE. Node-positive patients were allowed, and for the node-negative patients, there were additional risk factors needed in order to define this increased risk of recurrence. But different from NATALEE, now also patients were included that had a tumor between 1 and 2 centimeters. So there's a little bit lower risk patients included from stage 1, but in general, they're patients at an increased risk of recurrence. The treatment which was planned was 5 years of giredestrant versus a standard of care endocrine treatment. Premenopausal patients needed a GnRH analog in addition to the giredestrant and in addition to the aromatase inhibitor if chosen as a standard of care treatment. And with tamoxifen, the addition of ovarian function suppression was optional. The invasive disease-free survival was the primary study aim, and the readout that we're saying now here was triggered by at least 336 invasive disease-free survival events, and the statistical analysis plan also included an interim analysis for overall survival at this time point of the events that were achieved in the invasive disease-free survival. So the first piece of information that we get from this trial is being in this flowchart, and they're always very busy, but it's worth to look at them a little bit more closely. In each arm, more than 2,000 patients were randomized giredestrant and standard of care treatment. And on the right side, you can see the actual number of patients who were treated with tamoxifen as a standard of care treatment. So it was the minority, about 16% of the patients. I want to guess that the majority of those were premenopausal, but it has to be acknowledged that the majority of patients in the lidERA trial were treated with an aromatase inhibitor, 84%. Down here, you see the patients who discontinued at a median follow-up of about 32-33 months. You can see here the discontinuations in the both randomization arms. 346 patients discontinued with giredestrant in the investigational arm. 108 of those were due to adverse events, and in the standard of care arm there were more discontinuations, 520, of which 166 were due to adverse events. So that's the first piece of information that we can see here, that less patients discontinued the treatment due to adverse events in the giredestrant arm. The patient characteristics were very balanced. We get information about premenopausal women and postmenopausal women, 40%, 60%. The stage distribution is, of course, stage 2, 50%, stage 3, 40%, and about 12 to 13% in stage 1. Not positive patients, not negative patients. We have over 800 patients, almost 900 patients that are node negative, and we have almost 50% being 1 to 3 lymph nodes, and 30%, about 1/3 of the patients, more than 3 lymph nodes. Previous chemotherapy in that population, it's an increased risk population. About 80% of the patients were treated with adjuvant chemotherapy. And these were the results that triggered an applause at this time point in the presentation in San Antonio. You can see that the Kaplan-Meier curves start to separate quite early, and the risk reduction is about 30% with a hazard ratio of 0.70 and a statistically significant p-value of 0.0014. At this time point also, the exploratory analysis was presented where we can compare the giredestrant either with only the anastrozole patients in the standard of care treatment or the tamoxifen, and as expected, you would see a much larger difference in the tamoxifen treated group with a hazard ratio of 0.73, and the majority of the patients, I showed it to you in the previous slide, 84% were treated with an aromatase inhibitor. The hazard ratio is 0.73, very similar to the overall population, and the confidence interval doesn't cross the 1 for that population. The subgroup analysis did not give us a hint whether there's a subgroup where this treatment would have a especially large or especially low effect. You can see here the patients with stage 1. There was a very small number of events in that group, therefore the confidence interval is quite wide, but otherwise there doesn't seem to be a subgroup that sticks out in either direction with a very good or very bad efficacy. So our surrogate markers for overall survival were presented as well, like here, distant recurrence-free survival. It seems almost the complete effect that we see with the invasive disease-free survival is also noticeable in the distant recurrence-free interval. Hazard ratio 0.69, Kaplan-Meier curves separate nicely. And here is the interim overall survival analysis that was pre-planned as per statistical analysis plan, hazard ratio 0.79. Of course, this is still immature data. We have to wait for a longer follow-up, but I think it can be noted quite nicely how the Kaplan-Meier curves start to separate after 1 year of the treatment with the giredestrant. The big question when we're introducing or when we're dealing with the endocrine treatments in the adjuvant setting is the tolerability. This is the general overview that most of the patients experience some kind of treatment-related adverse event, but it's more important to look at the actual side effects, as we learned that the endocrine treatments lead to frequent discontinuations due to side effects. The side effect profile seemed to be quite comparable between the giredestrant and the standard of care treatment arm. Specifically, the musculoskeletal arthralgia was very comparable in the both arms, but it has to be noticed if you look at the treatment discontinuations due to adverse events, that there were less treatment discontinuations already in a median follow-up of less than 3 years in the giredestrant arm compared to the standard of care treatment arm, which is very noticeable because that's what we're dealing with in clinical practice, therapy management and therapy discontinuations due to side effects. And if there's a perspective that we can improve that by a combination partner or by a treatment with another endocrine treatment, that looks very promising. There were also side effects that were more frequent, and they're down here in this table. Bradycardia was reported more frequent in the giredestrant arm compared to the standard of care treatment arm. Although the gradings were in the rather low range, grade 1 and grade 2, and also venous thromboembolic events were somehow a little bit more frequent in the giredestrant arm. So these are side effects we might be having to look out for, but they're also known for any kind of endocrine treatment, including anti-endocrine treatments and contraceptives. So with regard to the conclusions, of course, now with a very large study introducing a new endocrine treatment in the adjuvant setting, there seems to be, with a hazard ratio of 0.70 and an improvement of the 3-year invasive disease-free survival rate from 89.6% to 92.4%, a treatment that will be implemented in the adjuvant setting in the future once it is approved. And we have to figure out how to implement it together with the CDK4/6 inhibitors that are in a very overlapping population. There's a sub-study which was not reported yet in the lidERA, which combines the abemaciclib with the giredestrant. There's other trials going on with other SERDs that test the respective treatment upfront, like Cambria-2. There's other treatments that test the SERDs after the treatment with the CDK4/6 inhibitors like EMBER-4. So it will be very interesting. Now there's a very effective, quite tolerable SERD, another endocrine treatment available or will be available in that patient population, how we're designing our adjuvant treatment in the presence of other therapy options that are already there. Of course, Aditya Bardia was very happy to present this. It was a collaborative effort of TRIO and NSABP and the respective drug manufacturers to conduct this trial. And every time a large trial like that is positive, there was a big applause in San Antonio. Thank you for your attention here in Dubai.
Excellent. Thank you very much indeed, Professor Fahshing. Highly appreciated. There will be a panel discussion. This is a very important study, and we will discuss this one. So next presenter will be our very dear colleague and the most elegant oncologist probably in the UAE, Dr. Sonia Osman, consultant medical oncologist at Virgil Medical Hospital. Dr. Sonia is going to talk about 𝗦3 clinical trial.
Thank you very much. Assalamu alaikum. Good morning, distinguished presence. And first of all, I thank the organizer for this high-level scientific event. And thank you, Professor Fisher, for the presentation. So, and all my colleagues. So with that, I will talk about very interesting data about the EMBER-3 trial that is including actually the combination of imlunestrant with the abemaciclib in advanced breast cancer and efficacy in phase 3 trial. These are the disclosures by 𝗕𝗿𝗀 Professor Komal, which is very well known. This is actually the background of the study. We know that actually imlunestrant is the novo oral third generation. We know that also it is crossing, it has an effect of crossing the brain barrier, and also with abemaciclib, it has an efficacy for a population that are mainly mutation, ESR mutation, and that are expressing endocrine resistance. So in the actually, FDA approved imlunestrant with the hormone receptor positive HER2 negative ESR mutated locally advanced breast cancer with disease progression after at least one line of endocrine therapy. And the pivotal phase 3 EMBER trial actually in patients with hormone receptor HER2 negative advanced cancer who progressed after endocrine therapy with the CD4/6 inhibitor, and it has significantly improved the progression-free survival versus the standard of care, which is fulvestrant or exemestane in patients with the ESR mutation with a very good hazard ratio of 0.62. Abemaciclib and imlunestrant combination also significantly improve PFS versus imlunestrant as a single agent in all patients with a hazard ratio of 0.57 in all comers, and the safety profile of imlunestrant as monotherapy has been studied as well in combination with abemaciclib that was favorable. Imlunestrant and abemaciclib showed a very low discontinuation rate with 6%, similarly to fulvestrant plus abemaciclib, and lower than other available combination that we use in our regimen. So with that, we reported the updated results. This is the design of the study. Actually, the design of the study was actually randomized 1-to-1 by 3 randomized population. The primary actually endpoint was actually the study was designed for patients with the hormone receptor positive HER2 negative, men or women, pre or post-menopausal. Prior therapy was allowed with adjuvant hormonal therapy after completion of aromatase inhibitor and anti-CD4/6 within 12 months. So those are the population who are resistant actually to endocrine therapy or who progressed after I plus CD4/6. No other therapy for advanced cancer was permitted, and stratification factor was prior CD4/6 inhibitor and visceral metastasis and the region. So the first actually population were treated with the standard dose imlunestrant 400 milligram daily. Second population, standard of care endocrine therapy, fulvestrant or exemestane. And the third population, imlunestrant plus anti-CD4/6. You can see that the primary endpoint was comparison and investigator assessed PFS for A versus B in patients with ESR mutation. The second one was E versus B in all patients, and finally was the comparison between the imlunestrant abemaciclib versus imlunestrant as a single agent, and the exploratory endpoint was time to chemotherapy, chemotherapy-free survival, and PFS2. So with that, we see that the statistical consideration between the patients that have been in follow-up, the median follow-up of the patient by primary FS was 15.7 months, and the overall survival entering two was 28.5 months. In that, we can see that the patients who were treated with standard of care comparing to imlunestrant and abemaciclib was actually statistically important for the imlunestrant and abemaciclib.
So overall survival was only tested in corresponding PFS endpoint, and with 2 or 3 PFS endpoint being met, very limited cumulative alpha was passed to overall survival. Why I'm saying this? Because the combination with abemaciclib and imlunestrant showed actually clinically meaningful overall survival, but statistically it was not really meaningful. But we will see this in further slides. So the endpoint of PFS was seen actually for imlunestrant versus standard of care. The benefit of imlunestrant was sustained in patients with ESR mutation, as you can see here, and it showed a hazard ratio of 0.62 comparison to standard of care. The secondary endpoint, interim overall survival of imlunestrant versus standard of care at 50% in maturity of the study. Here you can see that patients treated with imlunestrant comparing to standard of care showed also a numerical improvement in median overall survival, and this is 11 months numerical improvement in the overall survival in patients with ESR mutation, and hazard ratio was 0.6. You can see here in comparison for across all subgroups of patients with ESR mutation favoring imlunestrant, even for PIK3 pathway mutations. With that, also the exploratory endpoint for time to chemotherapy using imlunestrant with ESR mutation population showed a good hazard ratio of 0.66. Imlunestrant delayed the need of chemotherapy among patients who presented with ESR mutation. And we can see also the primary endpoint was met. Actually, PFS give benefit for imlunestrant plus abemaciclib that was maintained in all population, not only on the ESR mutation, but all comers. You can see that the median survival was 10.9 comparing to 5.5, comparing imlunestrant use combination with abemaciclib and imlunestrant as a single agent. The PFS was positive. So with that also we can see that the subgroup analysis PFS for imlunestrant abemaciclib versus imlunestrant in CD46 inhibitor pre-treated population who had already been treated in the adjuvant setting and progress within 1 year. The median PFS met 9.1 months comparing to 3.7 months, which is really considerable. And with that, we can see that the PFS was met the criteria for the combination in patients previously treated with anti-CD46, which is very important to consider. So, and then we have the subgroup analysis actually for patients whether they have ESR mutation or no ESR mutation. The combination of abemaciclib and imlunestrant showed actually a median PFS which was 11.1 comparing to 5.5 for the patient who had ESR mutation. Without ESR mutation means like all combo of population, the combination showed eventually 9.2 comparing to 5.5 months with a hazard ratio that was 0.64 for all comers. And for the ESR mutation, as you can see, the hazard ratio was very important with 0.49, means almost 51% death reduction. So consistently benefit of combination with abemaciclib and imlunestrant was maintained regardless of the ESR mutation. This is very important to consider. At the end, we have also the subgroup analysis for the population who had PIK3 mutations, because now we have also other drugs that are for patients who express ESR and PIK3 mutation. And you can see that eventually for patients who had PIK3 mutations, the combination with abemaciclib and imlunestrant comparing to imlunestrant as a single agent showed benefit consistently regardless to the PIK3 pathway, with a hazard ratio of 0.57 for the PIK3 mutated population, and for the PIK3 pathway mutation that was negative, eventually almost 0.59 hazard ratio, 11.3 months comparing to 5.6 months. So with that, we go now to the subgroup analysis for the combination of imlunestrant and abemaciclib versus imlunestrant in patients with ESR and PIK3 mutation. As we know now, we do the test for almost all population when it can be done, and we know that there is several patients who presented with co-mutations. So you can see that in this kind of population who had eventually co-mutations, it was a very good hazard ratio ratio for the combination of 𝗕𝗻 and imlunestrant comparing to single agent imlunestrant with 12 months regarding the combination against 5.5 months, a hazard ratio of 0.48, which is actually very good. With that also, this is a very nice illustration of the benefit in all subgroup. You can see also for the ESR and PIK3 mutation at the end, the combination of 𝗕𝗻 and imlunestrant showed a very good PFS, and in all subgroup population, ESR mutated, liver metastasis, visceral metastasis, choice of previous anti-CD46 in the past, and duration of previous CD46, whether less than 12 months or more than 12 months, or eventually more than 18 months, also showed benefit in this kind of combination. So with that, we have also secondary endpoint interim overall survival. Here we are talking about overall survival, not anymore about PFS, because this is the study that showed eventually clinically meaningful overall survival with combination of 𝗕𝗻 and imlunestrant at 33% maturity in all population. You can see that the imlunestrant 𝗕𝗻 median overall survival not yet reached, and imlunestrant 34.4 months. Hazard ratio is 0.82, and without delay, the secondary endpoint of overall response rate, you can see on the up level and lower slide that there was actually the combination of 𝗕𝗻 and imlunestrant that showed in fact a very good overall response rate comparing either to imlunestrant as a single agent or standard of care endocrine therapy. And either patient had ESR or no ESR mutation, it was positive. The first subsequent treatment also using the 𝗕𝗻 plus imlunestrant was also delayed. As you can see here, any therapy for all kind of patients, endocrine therapy, targeted therapy, antidrug conjugate, immunotherapy was delayed when we used imlunestrant and 𝗕𝗻 much better than the standard of care or the imlunestrant as a single agent. The safety actually showed that there was remained consistent with no characteristic of imlunestrant, which is a very safe drug actually, and 𝗕𝗻 that we know the adverse events. And with that, we go for the conclusion that imlunestrant now as monotherapy versus standard of care hormonal therapy with patients presenting with ESR mutation, additional 14 months follow-up, clinically meaningful overall survival improvement was observed, 11.4 months difference, hazard ratio 0.6, and the boundary with the p-value was low for significant but was not achieved. Overall survival benefit was consistent across all subgroups. The sustained PFS with the benefit and delaying subsequent chemotherapy by 5.4 months, which is very meaningful, and continued safety profile with the non-oral cell specified safety findings was there. Imlunestrant combination with 𝗕𝗻 actually versus imlunestrant in all combo of population showed favorable overall survival with a hazard ratio of 0.82, but which is still positive with the p-value of 0.2. Median overall survival not yet reached. Imlunestrant combination with 𝗕𝗻 median PFS now extended to 10.9 months with a very good hazard ratio of 0.59. Consistent benefit across all subgroup, including patients previously treated with anti-CD46, and the safety profile was low discontinuation rate relatively to available combination treatment that we use. In conclusion, imlunestrant as a monotherapy or combination with 𝗕𝗻 provide all overall chemotherapy-free options after progression on endocrine therapy for patients with hormone receptor positive, HER2 negative, locally advanced breast cancer. With that, thank you very much for listening to me. Happy to hear the questions.
Well done. Thank you so much indeed, Dr. Sonia, for this very elegant presentation. So with that, it's my absolute pleasure to introduce our dear friend and colleague, Dr. Hassan Ghazal. He's a consultant medical oncologist at Zahra Hospital, going to discuss the pooled analysis of brightness, CALGB 40603, and the 𝗕𝗎𝗀 looking at the neoadjuvant carboplatin PCR in the triple negative breast cancer. Dr. Hassan, thank you.
Thank you. No debate today, so. Okay, Assalamu alaikum, good morning. The room is full, so that's energy on Sunday. Okay, so I was given a task to talk about, again, question of carboplatin. We just heard update in the HER2 positive, an important update also, that carboplatin may not be needed in all cases when we are using anti-HER2. So this one is along the same lines, but taking the triple negative population. This is the disclosure from Dr. Fleischen. Okay, so the background and motivation that we have been adding carboplatin in the neoadjuvant setting initially without really complete data. And then when we had the KEYNOTE-522 trial, it established a new standard of care for those stage 2 and 3 triple negative breast cancer. And we saw consistently that when we add carboplatin to the mix, we are getting a better PCR rate. But it was not widely adopted as part of the standard of care until its incorporation in both arms of the KEYNOTE-522. Of course, the problem is it is toxic, so it's an added toxicity when we are giving, taxane in particular, and in this case, we are giving anthracycline, cyclophosphamide. So you are giving the kitchen sink, as we say, so you are adding a fourth chemotherapy agent, in this case, carboplatin. So, of course, we want to be sure of its efficacy before we add this potentially toxic treatment on top of everything else. So this is a pooled analysis of all these trials. You can see the details, the brightness on top and the 𝗏𝗏 and then the 𝗕𝗏6 Each has different design in the way you can see the coloring. In particular, the red ones are the carboplatin. So you can see some gave carboplatin on a weekly basis, and the other two, top two, gave every 3 weeks. With, of course, paclitaxel included in addition to doxorubicin. Now, the combined analysis here, 1,084 patients. So that's the power of when you combine trials, you get over 1,000 patients. And we're trying to look at the impact of carboplatin addition on the PCR rate and then also on the EFS and survival, overall survival. Clinical characteristics were well balanced. It's important to try to see about 80% in the brightness had the T0 to T2 lesion. The T3 to T4 were in the range of 10 up to 30%. So some discrepancy in the T3, T4, being the lowest was the 𝗕𝗏6 and the highest in the 𝗏𝗏. When you look at N positive, it was more or less equal, 44, 47, and 38 in the 𝗕𝗏6. So again, perhaps a 𝗕𝗏6 in terms of T3, T4, or N positive, little bit lower percentage. In terms of grading, again, talking about triple negative, grade 3 were the highest, obviously, ranging from 70 to 87%. Now, BRCA is important because this is one of the group or highest group we may expect to find BRCA mutation. And again, the range here was around 15% overall, with the lowest in the 𝗏𝗏 about 9% and the others in the 16% range. So again, matching what we expect from this population. And then the carboplatin use, you can see overall 60%, again 74% in the brightness, and about 50% in the 𝗕𝗏6. So some difference in the percentage of use of carboplatin. And then comes to the PCR in the breast and axilla, YPT0, YPN0. You can see more or less uniformity in the numbers around that 48 to 49%. So almost half the patients did achieve PCR, and they were around equal in all these subgroups. Now, multivariate models also included the T, the N, the degrade, the germline mutation, as mentioned here on this table. So in general, the response rate, as you can see, the PCR rate was 55% when we add in carbo versus 38.9 without carbo. This is all comers. However, when we try to dissect on the numbers, especially in the BRCA mutation versus not, something strange we noticed, counterintuitive in a way, that those who have a mutation in the BRCA did not achieve much benefit. So most of the, or all the benefit, you can argue, was driven by the wild type BRCA, where you can see the hazard ratio, certainly 2.1 versus 1.0. Now, arguably, the numbers become smaller, but still the signal should have been, or in theory, it should have been the other way around, where we think platinums are important when you have BRCA mutation. When you look at different studies, you can see the all favoring the carboplatin addition, more in the brightness perhaps, but you know, all of them you can see not crossing the boundaries. Now, when this is on univariate analysis, when we look at multivariate analysis, again, same, there is just a slight shift from 1 to 1.35 in the BRCA mutation. Still, the signal the same, that the wild type are the major group that is really driving the benefit. And you can see the 3 studies also still showing benefits. Now, when we look at, this is in tabular form, the BRCA mutation without carboplatin, the gray color, you can see the response 35%, and it goes up to 54% with the addition of carboplatin. And then when we look at the mutant, you can see pretty much the same exactly, almost to the decimal, 56.1, 56.2. So if you have a BRCA mutation, carboplatin addition really did not add much in this case in terms of the response rate. Now, when we look at EFS, of course, we always look at PCR because it's the easiest to measure, but then we always want the clinical correlation, in this case, the EFS. And you can see the carboplatin arm is on top in terms of EFS. At 5 years, 69% if you had no carboplatin versus 77% when we add carboplatin. And you can see again in the univariate analysis and in the multivariate analysis, the shift always is in the left side, which is the carboplatin, better EFS with carboplatin. More pronounced in the brightness trial. And then when we look at the mutant BRCA, another important observation, you can see that better EFS, you know, with carboplatin versus the wild type. So again, opposite to the PCR. So a little bit counterintuitive again, that we have seen more EFS benefit when we add in carboplatin in the BRCA mutation patients. Now, when we again look at the different curves in terms of EFS, wild type, no carboplatin, the lower gray, wild type with carboplatin, the light pink on top. And same thing when we have BRCA mutation with carboplatin is really the top curve versus the lower dark curve with the no carboplatin. Number of events, you can argue were low, but still, I mean, this is a good 5-year EFS update. Now, OS was not statistically different. So we have EFS, but not OS. Overall, you look at the subgroup and the mutant or wild type, or you look at different trials. Although the trend is there, again, the red curve is the carboplatin. You can see 84 versus 78%, but it did not reach statistical significance. Then they tried to look at something called gene expression analysis, different CD8, IgG, immune TCGA, all these signatures, and trying to find out if we can predict something from these gene expression. And I will add to that, we have already data on tumor infiltrating lymphocytes or TILs being a strong predictor. But here they were trying to measure specific signatures. The bottom line, the top four here, and the colored box, did have a correlation with our predictive power to the endpoints, which is PCR, EFS, or OS benefit. You can see the end here on the survival, where they are all shifted. So in conclusion, in a pooled analysis, again, remember these are taking 1,000 patients from 3 different trials. The addition of carboplatin to neoadjuvant chemotherapy was associated with what we know about PCR. Yes, it is higher PCR and better EFS. In germline BRCA1 or 2 mutation, the addition of carboplatin did improve EFS, but not PCR and not OS. Many immune-related gene expression signatures were predictive of a PCR benefit and were prognostic for survival as well. So obviously more work to be done to really identify, are there a particular gene signature? I mentioned TILs because it's been also in the news to predict who really respond or benefit more when we add carboplatin. And then acknowledgement to patient and all the different groups. And that's it up. Thank you.
Thank you very much. Thank you. Dr. Hassan, if you'd be so kind to join us here, and if I can invite all the speakers, please, and Professor Hlamed to join us here on the podium so that we can have a little bit of discussion. So Dr. Sonia, Dr. Fathi, Professor Fashing. I think Dr. 値î is still with us as well. Please, that would be a pleasure. Right, so we've had quite a few very interesting studies, and I think, you know, if we start with the first one, perhaps looking at 𝗕𝗏 and PATINA clinical trial, and you know that is really very interesting. Obviously, very nice strategy. TCHP, then you receive this as maintenance therapies. And now, as Professor Nciî very nicely summarized everything in a table, we have quite a few options, and some of these options, they are not very easy pills to swallow as well, such as tucatinib. And I think it becomes a dilemma as what to do with these patients as well, whether we should actually continue or use TCHP and then switch to PATINA and 𝗕𝗏, or whether we can actually use DESTINY-Breast05. I was wondering, maybe we can have a little bit of discussion. Maybe we can start from Dr. Nciî, who is on the call as well, to see what would be his kind of patient stratification when he sees such a patient.
Yes, hello, thank you. Actually, as you said, first of all, thank you all. I missed you, and all the presentations were great. Now, as you mentioned, you know, I tried to summarize this in my presentation. I think we now have the 3 or 4 options, I think, are still there for upfront, talking upfront. If we have a patient who has a high load of disease, short disease-free interval, visceral disease, we tend more, I think, to choose the T-DXd option. I think this is most reasonable. Also, we know that patients with mutated PIK3CA, I think from the HER2-low studies also, that they were ER-positive PIK3CA, also they benefited more from having the T-DXd. So those are the patients. Now, if you have a patient who is de novo, in the HER2 climb, Dr. Hikmat presented, I think like 70% were de novo patients. And ER positive, yeah, you know, and ER negative, I would go for TDXD, I mean THP, really confusing all this. THP induction, 6 to 8 cycles, and maintain with tucatinib. For patients who have ER positive, the data, you know, with the PATINA trial is very impressive, and it's very well tolerated, much less toxic. Start with THP and maintain the patients if they are ER positive on palbociclib with endocrine therapy. Now remains, of course, the other option. I think many of us will do it probably even before the results of the Demeter trial, you know, to give induction. Start out with TDXD, with pertuzumab for maybe, I don't know, 6, 8 cycles, whatever, and then maintain on THP. That is the main thing, I think, with the, you know, to avoid toxicity. We know that we all have patients who survive a long time with HP, and that would be difficult in terms of giving treatment every 3 weeks and toxicities of TDXD for so long.
Sure. I mean, one thing that I wanted to ask here, obviously, with Destiny Breast 09, we have a PFS of 40 months. When you look at, for instance, HER2CLIMB-05, that is like 26 months with that strategy. Again, of course, you know, that would be an easier decision to make, to give THP, continue with PATINA, which gives you more or less 46 months of PFS. But, you know, to just drop the PFS to 26 months in the one that are HER2 negative, you know, the question is that why don't I just continue with TDXD in those cases? What do you think?
Yeah, why not? That's the question. I think when you're looking at, already we know this from some real world data, even if you're looking at TDXD in the HER2 positives, according to Destiny Breast 03, there's a large amount of patients where the doctors together with the patients decide after 12 to 14 months, because of fatigue, because of the side effects, it's just too much. So the therapy is not tolerable that long. And I think with the HER2CLIMB-05 study, there's nothing wrong with the study. I will definitely, in the hormone receptor negatives, put my next patients on the HER2CLIMB-05 scheme and see how it's going. So it's convincing enough to do that. What now is lacking is we have the Destiny Breast 09 study, and not only me, but also other experts are hesitating. Is it prime time to give it to every single patient, even if there's no overall survival benefit yet? Maybe there will not be an overall survival benefit, we have to wait. But many doctors and experts hesitate, is it prime time for every single patient? I've already given it to some of my patients, but not to everybody, because pertuzumab, trastuzumab, and the taxane is so tolerable, and we're so used to giving it for a half year, the chemotherapy, and then stop that therapy and give the patient a phase where the quality of life is very good. I think to close this chapter, we can apply HER2CLIMB-05 now, you know, to our hormone receptor negative patients, but we do need a study. Start with TDXD, and then do a maintenance therapy for the hormone receptor positive according to PATINA, and for the negative ones, either with any of these new, there's other antibodies around, there's other TKIs around, the tucatinib is around, there's enough substances to choose from for some kind of maintenance therapy after an induction with TDXD. I think we need that trial soon.
Just a comment on your, I don't think you can cross compare and look at just PFS, because in that study, the control arm was only 16 months. So we improved from 16 months to 26 months. I'm not sure why it was so low. So, but I don't think you can just take the PFS 44 versus
No, I completely agree.
26.
But
you know.
even if you look at the delta is much better on
Yes,
the
yes, no, I agree.
I think, that is but at the same time, this is one point, and I think, all of us, we agree that maintaining TDXD on a long period of time may be challenging, but at the same time, again, to tucatinib, 75% of your patients, they come with diarrhea. Again, really, I mean, if we are concerned about 12% ILD, 13% of your patients, they have a grade 3 diarrhea, ended up being admitted to hospital. So I think, this is also a balance that needs to be made.
Other missing information was Dr. Hikmat mentioned at the very end. We don't know if you give tucatinib at progression is the same. So that's another thing to avoid the toxicities.
Yeah, I mean,
If I may add one word, may I just, to what Peter said, I think it's important also patients who have like a short disease-free interval, when they recur after adjuvant, neoadjuvant therapy for a short period of time, less than 12 or less than 6 months, definitely, we would go for TDXD.
Yeah, I totally agree. I think we can't ignore TDXD in HER2 in this group of patients. It's a very powerful drug, but as everybody says, it's the concern about long-term use and the toxicity. Now I'm going to shift the gear. I have a question actually about the 𝗔𝗕 and adjuvant setting. Now this is the biggest issue, and we're going to face very soon once the approval comes. How are you going to integrate this with the CDK4/6 inhibitors era as well? And definitely, as you said very elegantly, there will be many overlapping patients. So many thoughts how we can figure out how we're going to use this drug, because it's absolutely great. Actually, the data is very impressive, but more importantly, it's more tolerated than aromatase inhibitors, or better tolerated. So it gives me very incentive to use it straight away once it is available. But how we incorporate it with the CDK4/6?
Of course. I mean, first, the population of both lidERA and NATALEE are very similar. And they're patients that have an increased risk of recurrence. It's like the top 65, 70%, the top 30, 35% of patients with the highest recurrence risk. And we see that in the population, the recurrence risk seems to be high enough that 80% of these patients still get a chemotherapy at a time where we almost don't give any chemotherapy anymore compared to 30 years ago. So it's a high-risk population, and I want to be, like, my personal opinion is, I want to be ambitious. I want to get the most efficacious treatment to these patients to prevent as many recurrences as possible. And Dr. Sonia has very nicely shown the data of the EMBER-3 trial. I think we overlooked something in the combination between SERDs and CDK4/6 inhibitors. Suppressing cell cycle and now having a super efficacious suppression of the endocrine pathway, there seems to be some kind of synergistic effect that we did not expect in that extent that we've seen in EMBER-3. So I want to take this knowledge and say we should be ambitious and first exclude that we shouldn't give all the patients a combination. So CAMBRIA-2 study is going on, and there's discussions from others to also start more trials in the upfront therapy setting. So I hope, for the sake of the patients and doctors being ambitious to get the best treatment, that this is a treatment that can be established. And lidERA has a small subpopulation where it's combined with abemaciclib. But you also have to acknowledge that in many regions on the planet, resources is a big problem. If you have all patients on CDK4/6 inhibitors, some healthcare systems are just overwhelmed with the workload that comes along with the therapy management of the CDK4/6 inhibitors. And in some countries, this is leading to not all patients being put on a CDK4/6 inhibitor. Now, the question is, will the 𝗔𝗕 be cheap enough for these healthcare provision settings that it can be given in that setting? We already know that the elacestrant is super expensive, and the imlunestrant is just in the process of finding their price internationally on a global level. So it's going to be a very interesting situation.
So, Peter, if
Just
you
one
look at
point on that same study, do you think that you mentioned the discontinuation rate, there were 300 versus 500. Do you think that was a factor perhaps also? Or do we know these who discontinued AI, were they offered giredestrant, or we don't know what they received?
Well, they can, in the trial, they were allowed to continue on another endocrine treatment. You know, that was part of the study protocol. If you stop giredestrant, you're allowed to continue with another endocrine treatment. You're still part of the...
But some of them may not have received anything, right? On AI especially. My point is, would that be a factor in the overall outcome? I mean, there is significant difference in the discontinuation.
Possibly, but in the standard of care treatment arm, what's the option then? Or
steroidal AI.
Well, of course, the patients in the other arm, they're going to be treated as per standard of care, what we do when the patients have the side effects. And we all know that we're switching around the aromatase inhibitors, we're switching around to the tamoxifen before we give up. But at some point...
They didn't present that data, what I'm saying. They didn't present those who discontinued what they received, or they may have discontinued everything.
Not that I'm aware of, but you've seen the discontinuation rate due to adverse events in the standard of care treatment arm was around 160 patients, and was just like a little bit more than 100 patients in the giredestrant arm. But they continued endocrine treatment, of course, afterwards.
So I'm mindful we only have 3 minutes here on the clock, and I wish Sonia had presented EMBER-3 when we had that discussion. Now, obviously, we have the PFS of roughly around 10 months or so with IMLU plus abemaciclib, and we have more or less the similar kind of PFS if you look at other strategies as well that we discussed before. So what would be the addition of CDK4/6 inhibitor over and above something, for instance, giredestrant plus everolimus? Why would we use this combination, do you think?
Interesting question. So actually, you can see first of all, this is mainly for all comers, the combination. And for population who had ESR mutation and PIK3 mutation, also it showed PFS. And there was clinically also overall survival met and delay of the subsequent chemotherapy. Secondarily, the safety profile was equal to the safety profile of use of abemaciclib. There was no more adverse events. So this is, I mean, there is a lot of now studies that are actually using the combination, but I think that was superior to the other combination with the everolimus and therapy.
Well, close. No, I mean,
no,
I think
it's close,
you are hitting that 10 months. Yeah,
Yeah.
you cannot.
If you have a patient post first-line CDK4/6
Sorry,
inhibitor
one
and
thing.
endocrine therapy,
Yeah.
and there are all sorts of mutation, you know, ESR1 mutation, PIK3CA mutation, or if you don't, you know, what would you use? You do again, you know, this patient who's been on Abema, you just give Abema and imlunestrant, or you switch to something newer.
But here for patients who were actually progressing after 12 months of use of abemaciclib also, there was a huge benefit for the combination.
Yeah. I think we don't have head-to-head data, so basically whatever available to you. But I'm probably will change the whole strategy not to continue Abema. And if anything, we're going to do that, probably we'll go to SERENA-06. That's even better before. I think this is where we are heading now, especially in UAE. But if I have a patient today and I have ASR1 mutation, I would be hesitant to use monotherapy. I would try to use combination because of the modest benefit from monotherapy. Only exceptionally frail elderly lady with a couple of bone lesions, I may. But otherwise, I think immunostatin is only approved as a monotherapy, not yet as a combination. It's not available. Giredestrant is not available yet. So probably I will use elacestrant everolimus, or I continue with Abema, especially if the patient wasn't balbo or ribociclib. So there's so many options.
It's kind of pick your
If I may
toxicity
add
also.
just a word here, may I?
Yes,
Just for the combination of SERDs and CDK4/6 inhibitors, I think we have now the EMBER-3 as we heard, and also the ELEVATE trial that added elacestrant with abemaciclib also. So it looks like we will be using more this combination. It seems feasible, especially I think that CDK4/6 inhibitor are coming to the point where we're having generics. And even the patent, the original drugs, they're reducing their price. So I think we will be using more.
Well,
because
just one comment.
the price is getting
The
lower.
FDA, so the FDA never gave the combination the approval, and I think was mainly because they did not have an arm with fulvestrant abema, which based on the previous Monarch trials. So what is your comment?
Also, sorry, it's just the iliministrant is also crossing the brain barrier. We know like abemaciclib also has a certain effects of the metastasis to the brain. So the iliministrant also has this like benefit. Yeah.
So Peter, can I ask a question? Imagine
May
that
I
you
ask
have
Hassan a
access.
question?
Yes.
May I ask Hassan a question?
Yeah,
He
of
always
course.
asks the questions.
أول شيء ناجي الحمد لله على السلامة. I just heard you were sick from Marwan. الحمد لله على سلامتك.
No, just fibrillation and now in sinus.
Fibrillation.
Now in sinus. Some people are now talking about using more and more carboplatin in the neoadjuvant setting and adjuvant in early triple negative breast cancer. Some people even want to drop doxorubicin. Now with the data that you just presented, that the benefit may not be that outstanding as we always thought.
Well, it depends which endpoint you are looking at. If you are looking at EFS, there was benefit. Survival, of course, is harder to prove. And these are 5 years follow-up, but they did not see, there is a signal in survival, but not statistically significant. But remember, we're throwing over 1,000 patients here. I think there is a signal in PCR, no question. If you take the overall population, if you believe PCR is a surrogate for what's coming, then yes, PCR is higher when you add carboplatin. I think the counterintuitive, what we saw was the BRCA mutation group, although they had not seen better PCR, but there was better EFS. So if we are, again, what's important to us is EFS, you can take it as at that value and say carboplatin is positive in all these subgroups. But I mean, you want to give your patient the best chance at that neoadjuvant setting. So I think I had minimal toxicity when we adding. You have to be careful. AUC 1.5 addition is not too toxic. I don't use AUC of 2, it become more toxic. So if you use the weekly 1.5, I think it's a tolerable regimen. And you are only giving 12 weeks. So overall, I had very good success with my patients.
I have two questions here. One question to Peter, assuming that you have access to camizestrant in SERENA-6 here that we're going to have in the next couple of months, hopefully. And with the data that post-progression here, would you choose your patient to go to SERENA-6 strategy, or would you wait until radiological progression before you actually consider SERD in the second-line setting?
Well, camizestrant is not available yet, but I mean, we have some experience with it and we already have plans, what to do. The question is maybe not more like what's happening in SERENA-6 and after, but what's happening in SERENA-6 and before. I think everybody hopes for SERENA-4 or Pioneer or whatever to be positive when you start the SERD up front. Everybody's hoping for that. So everybody's a little bit in suspense, waiting, it's like, when will this data come? It might take a little bit more time for this to arrive. But up to then, with all the criticism for SERENA-6 that I at least partially support for scientific study design, the study is positive. It adds 7 more months of PFS. And when the patient sits in front of me, all I need now is an easy and cheap blood analysis for ESR1. If that would be as easy as just making a blood draw, getting the result back a few days later, there's no harm in it, So I would give the patients 7 months of PFS in the first-line setting, hoping for that SERENA-4 or Pioneer will report that we don't need any testing in the upfront setting, but I would not wait for the second-line setting as early as possible. No progression, better quality of life. I think for the patient that's sitting in front of me, it's a very simple idea.
Then we will face the patients who progress on adjuvant SIR, and then we'll carry on with this.
Dr. Naji, is that what you also do? Assuming that you have availability of camizestrant?
Well, we have not yet done that. You know, we don't have it available. So
I know, but I'm asking you, what would you do?
Available.
It sounds reasonable, but I think we still need to wait for more follow-up data.
Agree.
Okay.
Whether to
Last
start it
question.
now or later on, you know.
Last question. So obviously it was very surprising, Hassan, not to see PCR higher in the BRCA. Do you think that is that because, you know, do you have the data, whether because of, for instance, bone marrow suppression or the thing, delivery of carboplatin was insufficient in BRCA mutant patients?
I don't think they mentioned that particular point, but this is what I think. I think you are throwing the kitchen sink chemotherapy. All these patients got 3 other types of treatment, which we know may be also effective in the BRCA mutation. So how much carbo is adding on top of the other 3?
Must have been really that, you know, we don't have that data, but, you know, you caused so much toxicity with this one that you couldn't even deliver your normal chemotherapy anyway.
Yes, you're right. I mean,
Yes.
BRCA usually is synonymous to platinum
sensitivity.
But really quick, because we concern so much with it. There's 4 studies. 2 of them, one is 𝗕𝗿𝗀, which I published in JCO, and the Israeli study from Bella Kaufmann's group, where there's no connection between PCR and prognosis in BRCA mutation carriers. So you have higher PCR rates, but that does not translate into a prognostic benefit. And there's 2 other studies where it's the case. One is the 𝗕𝗿𝗀 study, where it is associated, and then another study that my group published, it is associated. So it's a still unsolved scientific mystery. 2 studies connect PCR with prognosis with BRCA mutation carriers. 2 studies don't. We don't know why.
Even the overall survival has become a problem. Anyway, so thank you so much. This was a really, really very nice and interesting discussion. Thank you, everybody, for your presentation and attending. Thank you, Dr. Naji. Highly, highly appreciate it.
Thank you.
We'll be taking group photo before everyone escape for lunch and after lunch. So please join us, Dr. Aida. And we need to call everyone. Dr. Arif, خلينا ناكل كوفي يلا. رياض. دكتور رياض. يلا. يعني أنادي واحد واحد. Everyone, doctors, physicians, pharma. دكتورة أكيد طبعا.
We work as a one from each institute in the UAE, literally.
Very good.
Yes.
I think that it's
Okay, so good morning, almost afternoon. Good morning, everyone. Dr. Falah. Where's Dr. Falah? Dr. Falah al-Khatib. We need Dr. Falah. Okay, so I'll start with the session. Hi, Dr. Falah, تفضل معاي على stage. So it's great to welcome you all in this very nice early afternoon. It's my honor to co-host you with the founder of Radiation Oncology, Dr. 𝗕𝗲 𝗨𝗀, a dear friend and mentor for many. We'll be talking about the surgical radiation local therapy part of breast surgery with a group of great surgeons, radiation oncologists, both regionally and internationally. So we'd like to welcome the first speaker, Dr. 𝗕𝗲 𝗨𝗪. Dr. 𝗕𝗲 is a very dear friend and colleague for all of us. She is dual boarded with extensive experience. I don't want to say how much, it's because she's too young to have this experience. But she'll be giving us nice talks, so I'll leave the title for you. Thank you. Hi, next. Hi, next. Okay.
Thank you so much, Ibrahim, for the introduction. And we always are 25. Remember, we stop at 25. So it is my great pleasure to be here. I would like to thank the organizing committee and Dr. Aida for inviting me to present at the Best of San Antonio, UAE. It's a very interesting abstract in the era of de-escalation that we are all living and discussing and updating, not only on the systemic level, radiotherapy level, but also on the surgical level. So today I'll be presenting in this abstract the AXANA study. This is a work by Dr. Kun and his team. He presented at San Antonio, mainly to go through the primary endpoint analysis of the AXANA study, looking at the recurrence, axillary recurrence rate, 3 years local recurrence rate in patients after neoadjuvant chemotherapy who converted to N0, and comparing the axillary lymph node dissection versus the other less extensive surgical procedure in the axilla. So this is the acknowledgement of the author. And you know, for patients who converted from N0 clinical, from N+ clinical to N0 after neoadjuvant chemotherapy, the axillary dissection, which are the standard, was de-escalating. Progressively, we were replacing with either sentinel lymph node biopsy or the targeted axillary dissection or targeted lymph node biopsy. However, the oncologic outcome data between the different techniques are still very scarce, and there were mostly retrospective analyses. There was one prospective study comparing sentinel lymph node biopsy to targeted axillary dissection, and all the studies have shown so far low recurrence rate at the axillary level. The impact of risk factors are yet to be analyzed, and additional data from prospective large study are really needed before we generalize into guidelines and into the practical practice. So this study, AXANA study, is an ongoing international multicentric prospective registry. Patients with the clinical N+ converting to N0 after neoadjuvant chemotherapy were included. The axillary surgery was either axillary dissection, targeted axillary dissection, targeted lymph node biopsy, or sentinel lymph node biopsy. Now, the neoadjuvant chemotherapy that was given or the regional radiotherapy, it depended on each country and each region guidelines and recommendations. The first co-primary endpoints were axillary recurrence-free survival, the invasive breast cancer disease-free survival, and the quality of life and the arm morbidity. Now, because the axillary recurrence happened early, so they checked first, they aimed first in the analysis, the co-primary endpoint of the 3-year axillary recurrence-free survival for axillary lymph node dissection versus the less invasive procedure. They also analyzed the same axillary recurrence-free survival for sentinel lymph node group versus targeted axillary group, and they looked at an interim analysis for local, regional, distant recurrence-free survival, breast cancer-specific survival, and the overall survival. This was the primary analysis that they did and presented at San Antonio. So in a predefined statistical analysis, they defined as less invasive axillary staging is considered non-inferior to axillary clearance at 3 years if axillary recurrence-free survival is above 97% based on the confidence interval that they took. The Cox hazard ratio were analyzed with a p-value less than 0.05 and the Kaplan-Meier curves for the survival. Now, the trial included patients from over 288 sites in 26 countries. And as you can see in those colors, you can see the variation, the multitude variation in how they perform the surgery for the axilla, depending on the country, depending on the surgeon. So there was really a multitude variation in the way they proceeded with the axillary surgery. Out of 6,474 patients, there were only 2,600 that met the criteria, with axillary lymph node dissection in almost 800, sentinel lymph node biopsy in 400, the targeted axillary dissection, which includes sentinel lymph node and targeted lymph node, in 1,400, and targeted lymph node biopsy only in 15. So they ended up including YNPN0 and YPN+, with a median follow-up of 2 years and the nodal complete response in 50%. When they looked at the patient characteristic comparing axillary lymph node dissection to the less aggressive surgery in the axilla, sentinel lymph node, TAD, or targeted lymph node biopsy, they found that in the group of axillary dissection, the patients had higher risk when they looked at the T stage, at the size, when they looked at the nodal burden. Now, they had more mastectomy and more regional radiotherapy. However, there was no significant difference in the other median age, tumor subtype, the complete response in the breast, or the regimen of chemotherapy and regional radiotherapy. When they looked at the axillary regional treatment characteristics, in the patient who converted to PN0, there were regional radiotherapy in 47% and 53% in either the axillary lymph node dissection or the less aggressive surgical procedures. When they looked at the group where there was residual N+ after neoadjuvant therapy, they gave adjuvant radiotherapy in 63% after axillary clearance in the axillary group. Now, in the less aggressive surgical groups, they completed with axillary clearance and radiotherapy in 42% of the cases. Only axillary clearance in 26%, only radiotherapy in 23%, no axillary clearance and no radiotherapy in 8% of the cases after residual and positive. Now, those were highlighted by the authors. And looking at the 3-year axillary recurrence-free survival, as you can see, 99% in the group with axillary dissection, 98% in the group of less aggressive surgery. So if they look at the curve, they both are higher than the confidence interval, and they concluded that it is targeted less aggressive surgery in the axilla is non-inferior to axillary lymph node dissection when we look at the recurrence rate at 3 years survival. Now, when they look at all endpoints, oncological endpoints, they found that the higher risk in the axillary lymph node group was mostly about distant recurrence, invasive cancer recurrence, and overall survival. However, when they did the multivariate analysis, there was no difference in general between both groups. Now, they compared also sentinel lymph node biopsy versus targeted axillary lymph node biopsy, which includes sentinel lymph node to the targeted lymph node biopsy. Again, when they looked at the characteristic of the patients, sorry about that. When they looked at the characteristic of the patient, only the T was like more in the sentinel lymph node group, so the size, but not the lymph node burden. And there was more radiotherapy in the sentinel lymph node group. However, the median age, the size of the lymph nodes and the number, the subtypes, the type of surgery, the regimen, chemo or radiotherapy did not differ between both groups. And in those who converted to complete and zero, the radiotherapy, adjuvant radiotherapy was almost similar, 65-49. And in the cases that converted to an plus, they stayed with N plus. So the complete axillary clearance and radiotherapy was 49 and 40% in both groups. Complete axillary dissection without adjuvant radiotherapy, 20% in the sentinel node, 27% in the TAD, and no axillary or no radiotherapy in very low number. And again, when they looked at the recurrence at 3 years in the axilla, there was no difference. So it was not inferior when they did the statistical analysis. You can see 99%, 98%. And in that group, sentinel lymph node versus TAD, when they looked at the general endpoints, overall survival and other survival, there was no difference between both groups. So in conclusion, AXANA study, a prospective international multi-center study reflecting real-world data from many countries, many institutions, confirmed that axillary recurrence-free survival following either sentinel lymph node, TAD, or targeted lymph node is excellent and not inferior to axillary lymph node dissection at 3 years for patients who converted from clinical and positive to clinical and zero after neoadjuvant chemotherapy. In addition to that, no difference was observed between TAD and only sentinel lymph node biopsy. The findings were independent on the initial tumor stage, nodal burden, subtype, despite, as you have seen, a large heterogeneity in the regional therapy. What was really surprising that how it was different from a country to another, from an institution to another. Now, definitely higher initial risk was associated with more distant recurrence, but not with regional failure. So this is where the systemic treatment, I think, is still playing a big role in even if we are de-escalating at the surgical level and the regional level. Regional therapy was in these all observation heterogeneous in the PN0 and PN plus group. So definitely detailed and more analysis are ongoing and we'll be giving more conclusions in the future. Further follow-up is necessary to assess the long-term results. Now we are at 3 years, but definitely long-term results for the staging, for overall survival and the local management. Thank you so much.
Questions now or at the end? At the end? Okay, sure. So moving on, it gives me great pleasure to introduce Dr. 𝗦𝗫 𝗨𝗪. Dr. 𝗦𝗫 is the head of the breast unit at the American Hospital Dubai with a highly accomplished surgical. She was actually the first female to do a robotic surgery in Dubai and moving things forward in the country. So thank you so much for being with us today and discussing the next abstract.
Thank you so much for the kind introduction and thank you for the invitation to speak in this conference. I use this. Okay, so I'm going to discuss the secondary results of the 𝗦𝗫 trial that was presented in the last San Antonio. In the previous San Antonio, the primary results of the 𝗦𝗫 trial were presented, and I assume we all know of them, where they showed that the omission of axillary surgery did not result in inferior invasive disease-free survival compared to the standard SLNB in early breast cancer with breast conserving surgery. That was the first randomization. And the second randomization is one of the ongoing trials that are trying to validate the Z11 results, evaluating sentinel lymph node biopsy alone versus completion axillary lymph node dissection in patients with breast conserving surgery and involved lymph nodes up to 3 lymph nodes. So the goal of the second randomization was to demonstrate that sentinel lymph node biopsy alone does not result in inferior invasive disease-free survival compared to the completion axillary lymph node dissection in patients with N1A breast cancer with breast conserving surgery. So here we can see the whole design of the 𝗦𝗫 trial. They recruited at the beginning 5,230 patients per protocol. The first randomization was 1:4. The 1:4 randomization was in order to have more patients undergoing sentinel lymph node biopsy in order to prepare for the second randomization. And the second randomization, they took the patients who had positive lymph nodes 1 to 3 and randomized them into completion axillary lymph node dissection versus sentinel lymph node biopsy. They also allowed direct entry to the second randomization. Patients that weren't randomized in the first randomization could enter the study at this point as well. So the analysis of the initially co-primary endpoint was performed on the per protocol set due to the non-inferiority study design. The Kaplan-Meier product limit method was used to estimate the 5-year IDFS rate, reported with a two-sided 95% confidence interval. The non-inferiority was tested based on the confidence interval of the hazard ratio from the Cox proportional hazard model to exclude the hazard ratio of 1.271 for the co-primary objective. That to correspond to the absolute decrease in 5-year IDFS rate from 81% in the completion axillary lymph node dissection arm to 76.5 sentinel lymph node biopsy only. The target number of patients was 1,968, which was not achieved due to multiple reasons. First of all, the rate of the macromets in the sentinel lymph node arm was lower than expected. They expected to have 25% positive 25% patients, and they had only 11.3%. The recruitment rate directly into randomization 2 was also below the planned numbers. And also by that time, the longer term results of the Z11 had already been published, and patients didn't want to undergo the completion axillary lymph node dissection when they already knew about the results of the Z11. So in 2018, the second randomization objective was downgraded to secondary outcome. And here we can see that a total of 485 patients underwent second randomization, and they were divided into 2 groups, intention to treat population versus per protocol population. And the difference is because there were 99 patients who underwent axillary surgery not according to the randomized arm, and 18 did not receive post-operative radiotherapy. So that resulted in this discordance between the 2 groups. Here we can see that the baseline characteristics between the 2 groups were quite similar. And we can see that there was a trend towards higher Ki-67 in the completion axillary lymph node dissection. The mean number of dissected sentinel lymph nodes was 2.4. The median was 2 in total. And the mean number of dissected lymph nodes in the case of completion axillary lymph node dissection was 13. Here we can see that radiotherapy was given more in the group of the completion axillary lymph node dissection. And that's probably because above 4 lymph nodes, they had to give radiotherapy, and they could reach that number only in the completion axillary lymph node dissection. This is the main slide of the whole study, basically, which was a surprise because they could not prove non-inferiority of the sentinel lymph node as opposed to the axillary lymph node dissection. We can see that the invasive disease-free survival rate, the 5-year IDFS in the sentinel node alone was 86%, as opposed to 94% in the axillary lymph node dissection. And we can see that the 2 graphs are separating at the end. This is in the per protocol group. Secondary endpoints events, the axillary, we can see that the distant recurrence in the sentinel lymph node biopsy group was higher than the axillary lymph node dissection, but the axillary recurrence was very low, was 0 in the ALND actually, and only 1 event in the SLNB alone. In the intention to treat group, the gap was a bit less than the per protocol, but still they could not prove any the non-inferiority margin that they wanted to prove between the two groups. The overall survival was in a better shape. So the overall survival in both groups was very close, 95% in the sentinel node alone, 96% in the completion axillary lymph node dissection. But we can see here that the confidence interval was very wide. So we cannot conclude a lot regarding these numbers. This is another diagram to show that there was clear advantage of the completion axillary lymph node dissection group in nearly all parameters. And we can see that patients actually who had larger tumors and more macrometastasis actually benefited less from axillary lymph node dissection. It's quite surprising as thinking of it. And also we can see that patients who were candidates of omission of SLMB, according to the new ASCO guidelines, also could benefit less from the completion axillary lymph node dissection. So the strength of this study is that it has data based on a very long median follow-up and highest axillary tumor burden of all the Z11 validation trials. The median follow-up and the patient's number with macrometastases are comparable with the first analysis of the Z11 trial, and there was prospective assessment regarding incidental axillary irradiation alone during the whole breast irradiation. But we also must speak about the limitations. The planned target recruitment number was not met. And the major crossover between per protocol and the intention to treat cohorts led to incongruent results comparing 5-year IDFS rate, significant differences regarding post-operative radiotherapy between the study arms, fractionation schedule, boost application, and radiotherapy. So conclusion, in the randomization, 2 additional data on the oncological safety of patients with completion axillary lymph node dissection omission following a positive sentinel lymph node during breast conserving surgery with a strict indication for radiotherapy and quality assurance. For the first time, these results suggest a potential impact of omission of axillary lymph node dissection on the 5-year IDFS. But the question is how are we gonna, is it gonna change our practice because of the number? Or are we gonna stick to the practice according to the Z11 and other validation trials? So the follow-up will continue and 10-year follow-up data are expected to be published in 2029. Thank you.
Our next speaker is Dr. Sangeeta from 𝗕𝗏 Medical Center. She's going to present the next paper.
Thank you, Dr. Fallah. Thank you to the EOS committee for inviting me for this talk. It's actually very entertaining, or sorry, enlightening actually, to come after Dr. Marianne and talk about the radiotherapy aspects of it, given the conclusions of what you have just said. But I will start off by saying this is from the first randomization. This result is from the first randomization, so it's not talking about the patients who are randomized between a sentinel node biopsy and completion, axillary dissection or not. So I'll skip through these very quickly because it's already been covered by Dr. Marianne. So the first randomization reports were, we know about them, omission of sentinel lymph node biopsy in clinically node negative breast cancer patients did not affect the 5-year invasive disease-free survival. But we also found out that the patient-reported outcomes and quality of life data were in favor of not having a sentinel lymph node biopsy. The 𝗕𝗏 trial did actually have a planned analysis of the radiotherapy quality assurance, and it did document the dose distribution in the ipsilateral axillary levels 1 to 3, and also where regional nodal irradiation was applied in these patients. So this trial is talking about, or this presentation is talking about that aspect of it. Now this is important because we do know that in the Z11 trial, which we use as the standard for omitting sentinel lymph node or omitting axillary dissection in those patients, we do know that about 50% of the patients actually were treated with high tangents, which then meant that about 60 to 70% of the patients received a therapeutic dose to level 2 axilla. So is that standard of care or not? We will find out from this. Trial design, as Dr. Marianne pointed out already, but this is talking about the secondary objective of the applied dose of radiotherapy to the axillary levels 1 to 3. So the ensema trial, whole breast radiation was mandated. Patients could not have partial breast irradiation even if they were eligible for it. Regional nodal irradiation was only permitted in patients with 4 or more lymph nodes, and the contouring of the axillary levels was standardized using the RTOG consensus definitions. And the dose parameters were actually, they allowed for different dose regimes. So the standard fractionation or the conventional fractionation or the hypofractionated regimes were both allowed, and therefore the parameters were presented as relative doses to make easier comparisons. And the QA, the RTQA was done by analyzing the first 3 radiotherapy plans per center of these patients who were randomized into the trial. And we can see that the contouring adherence was about 85%. 3D CRT, the tangential technique, was used in majority of the patients, 76%. Conventional fractionation, 2 gray per fraction, was more preferred. And boost was applied in 88% of the patients. This is interesting because as we move forward, we'll see whether this was actually necessary or not. That's a debate point. And they found that the incidental radiotherapy exposure to axillary level 1 was 50% of the patients received almost a therapeutic dose, which was described as an 85% or higher dose. But at least a quarter of the patients received the full dose of prescribed radiotherapy to level 1 axilla, which is understandable given majority of the patients were treated with the 3D tangential radiotherapy technique, and that would not be a surprise. Statistical methods, fairly standard. And this is the consort diagram. So if we see the intention to treat set, some of the patients could not enroll in, could not be analyzed. So they analyzed the per protocol set, which was what was used for the primary analysis of the outcome. So they continued to analyze on that set. Because some of the patients did not have postoperative radiotherapy, as 252 patients, and some patients did not have axillary surgery as per the protocol. Where we can see that about 15% of patients who had sentinel lymph node biopsy converted from a clinically node negative to a pathologically node positive N1 stage, and about 0.2% also had N2 disease. Baseline characteristics were fairly evenly matched between the 2 groups, but interesting to note that even though 60% of the patients were less than 65 years, the less than 50-year age group was only 10%, so it was not adequately represented. And majority of the patients, 90% of the patients, actually had T1 disease, although T1 and T2 were both allowed in the trial. Grade 3 was less represented, again, which is reassuring. And pathology-wise, all fairly well matched, and as anticipated, higher risk of, higher in population with non-specific pathology. ER/PR positive, higher in number, HER2 negative, higher in number. With regards to radiotherapy techniques, as we pointed out earlier, 3D radiotherapy was more common. IMRT was less so. And they integrated simultaneous integrated boost, deep inspiratory breath hold, etc. Fractionation, majority conventional. So the techniques were nothing unusual in the techniques or in the fractionation schedules. When we look at the whole breast radiotherapy parameters, this just gives an idea of what fractionation schedules were used and what the size of the PTV was. But you can see that they're fairly evenly matched between the two groups, so no differences between this to account for any changes. And the boost was also, again, evenly matched between the two groups, 10 gray in 5 fractions, standard boost dose applied. Boost volumes also fairly evenly matched between the two groups. Now, this is where the differences appear, or we feel they appear. So the patients who had no sentinel node biopsy, some of them did end up getting regional nodal irradiation. That would have been a protocol violation unless they did a protocol amendment at some point in time. I'm not able to say that from what is documented here in this slide. With regards to the sentinel lymph node biopsy arm, we already saw that there was a small number who ended up being N2 disease, but majority of them were still N1 disease. The median dose to the axilla, the level 1 axilla, the lower axilla, was slightly higher in the sentinel lymph node biopsy arm, not in the non-sentinel lymph node biopsy arm. So therefore, that needs to be just, let's just pause at that and we'll come back to that later, because that kind of removes the bias from the analysis, in my opinion. Level 2 axilla, again, slightly higher dose in the sentinel lymph node biopsy arm as a median, 37.8. But overall, as a percentage, it is still a low dose to level 2, lower dose to level 2, not comparing to the high tangentials in the 𝗕11 trial. Level 3 axilla received very little dose. So overall, with regards to the first 3 slides, what we anticipate with level 1 axilla being treated to about 80-85% dose with regards to the tangents and the body habitus, that is as anticipated. Level 2 did not receive an excessive dose, and level 3 did not get treated significantly. And the differences between the two groups, where the sentinel lymph node biopsy group appeared to get a higher dose, which was statistically significant, really does not change the outcomes, because it was not in the non-sentinel lymph node biopsy, so there wasn't an inherent bias in the people who were treating these patients. This slide, I would say, I would interpret it with caution, because this is comparing patients who were excluded from the per protocol analysis. So this is comparing patients who had radiotherapy with patients who did not receive radiotherapy with and without sentinel lymph node biopsy. This can only be an observation. We cannot draw any conclusions from this, in my opinion. So we see that there is no difference whether the patient received radiotherapy or not, and whether they had sentinel lymph node biopsy or not. Radiation or no radiation did not make a difference in the outcomes, is what they're trying to interpret, but this can only be an observation because it was not a planned analysis. So in conclusion, approximately 50% of the patients received a potentially therapeutic dose in level 1 axilla. Higher incidental dose was observed in level 1 axilla, in level 1 and level 2 axilla, in the patients who were in the sentinel lymph node biopsy arm as opposed to the no sentinel lymph node biopsy arm, and patients who did not have sentinel lymph node biopsy for some reason. Less than 1% of them actually did have regional nodal irradiation. We don't know what the reason for that was. And the last slide, as I said, we have to interpret with caution because it can only be an observation, cannot be interpreted more than that. So essentially what this concludes is that the radiotherapy, how I would interpret this is the radiotherapy treatment was standard. It was not attempting to include higher levels of axilla to compensate for the surgery. So as long as there is standard radiotherapy, then this trial can be interpreted as the results show. But then, of course, that has to be taken in the context of what Dr. Marian has just presented.
Thank you so much, Dr. Sangeeta. Lots of questions. I think next speaker is Dr. Thuraiya. Can we change the slide? So I'll introduce Dr. Thuraiya. She's a very dear friend and colleague of ours. She's the head of radiation oncology in Royal Hospital in Muscat, Oman, also part of 𝗦𝗔𝗕𝗬𝗀 Cancer Institute in Oman as well. We're lucky to have her, and she was here yesterday with us in Best of Astro, and we're also very lucky to have her to be with us in Best of San Antonio. Thank you so much for coming from Muscat.
Assalamu alaikum. Thank you very much, Ibrahim, and Dr. Aida, Prof. Hamid, for the invitation. I'm glad to be with you. So my topic today is about the primary result from the hormonal receptor positive, HER2 negative. It is a cohort of the 𝗕𝗏 trial. This is a randomized trial of no radiation or low or high dose preoperative radiation with pembro and chemotherapy in the node positive HER2 negative patients. So it was done by Dr. Gaurav Gupta. As you know that from the CheckMate 7FL and Keynote 756, there is increase in the pathological complete response with introduction of immunotherapy if it's added to the neoadjuvant chemotherapy. But the benefit was more with the high baseline of PD-L1 expression and the tumor infiltrating lymphocytes. The idea of this trial is that we want to introduce preoperative radiotherapy along with the pembro, followed by chemotherapy, followed by surgery, and then again radiotherapy to the breast and the lymph nodes. So, so the patient received preoperative radiotherapy boost to the breast only, but limiting the lymph node dose to less than 1 gram. Why is that? Because we want the cancer cells to be recognized by the immune cells and create the infiltration of the lymphocytes. So here is the randomization. It's mainly the high risk hormone receptor positive HER2 negative patients, T1C to T4C, and node positive patients were included. All of the patients received preoperative pembrolizumab, but they were randomized to 3 groups. So one group received no radiotherapy, 0. One group received 9 gray radiotherapy, and one group received 24 gray of radiotherapy. All of the patients then received neoadjuvant chemotherapy, and then they went to surgery, followed by adjuvant radiation to the lymph nodes and the breast to eliminate the microscopic disease. All patients received or got biopsy from the lymph nodes as a baseline, and then 2 weeks after the radiotherapy, and then at the time of surgery. So what was the primary endpoint? It was mainly the tumor T-cell infiltration at 2 weeks biopsy, and the study power to detect an increase in the upper quartile TCI from 25 to 55%. Other endpoints were the pathological response in the nodes, and also the composite PCR and the residual cancer burden. And other points were transcriptional signature, and this is mainly the microenvironment of the tumor. So in the 𝗕𝗏, the criteria were patients should have hormone receptive positive, should be ER/PR more than 10%, and the HER2 is negative. N1 to N3 disease were included, T1 to T4 were included, and the tumor features grade 3. Also grade 1 and grade 2 were included, and you can compare it to the Keynote 756 and CheckMate 75L, where they included only, or they were strict with the grade 3 disease. But in this trial, as you can see, grade 1, 2 forming about 37% of the population. And mostly they were T2 and T3 disease. So this is the primary endpoint. So it is mainly the T cell infiltration at 2 weeks, and this was measured by the breast immune score. Maybe too many information in the coming slides, but I'll try to make it simple. So they were mainly calculating the upper quartile. If it is more than 0.75, it means that these are T cell responder. So you can see here in the graph, if you can see the pink one, when it is pembro with the 24 gray, it is higher T cell responders compared to the other doses of radiation. And they found that the T cell responders, they have even higher PDL expression, as you can see in that graph. This is the volcano plot, and this is mainly to check that the pembro with the 24 gray causes immune activation. So the the black dots is insignificant, while the red dots, these are the top 10 genes, they were activated, and these are responsible for the T cell and the B cell activation and cooperation. And here are the top 20 enriched immune gene sets. So also they found out that the radiation with 24 gray and pembro increased the abundance of the tertiary lymphoid structure, and it was measured with the xenium spatial transcriptomics. Sorry. The surgical outcomes, they found out that with the 24 gray, there is more response in the lymph nodes as a co-primary endpoint. You can see here also the PCR was higher with the radiation treatment, but for me, I didn't understand why the 9 gray is more response than 24 gray. And you can see also the reduction in the burden of the tumor is less with the 24 gray. However, this study was not powered to detect clinically meaningful differences in these endpoints. And the extra points for analysis was, what are the predictors for the pathological complete response if we added pembro with RT? So they found that if it is non-luminal tumor, then it is more response. And also, if it is high PDL expression, there will be more response. So if you gather both points, so patient with non-luminal A and a high PDL expression, there will be more pathological complete response. So the conclusion is 24 gray preoperative radiation with pembro significantly increase the T cell infiltration in the node positive high risk, hormone receptor positive, HER2 negative early breast cancer. And also this is increasing the abundance of tertiary lymphoid structures containing B cell, T cell, and dendritic cells. And despite 50% of N2, N3, and 35% of non-grade 3 tumors, encouraging rates of PCR were observed in the RT and pembro arms. The exploratory analysis suggests that greatest benefit, if you add pembro and radiation, it is in the non-luminal A tumors that induce the quartile 4 PDL1 at the 2 weeks biopsy in typhoid. And then maybe they need further trials to check the role of radiotherapy if it is introduced with the immunotherapy. With this, I conclude my presentation. Thank you very much.
All right, great talk. Thank you so much, Dr. Thoraya. Our next speaker is, sorry, no, Dr. Hania. Dr. Hania Qazi. Yes, sorry. Hello, Dr. Hania. How are you? So our next is Dr. Hania. She's a consultant radiologist at 𝗕𝗏 Medical City. Really nice to meet you, Dr. Hania. Thank you so much for your talk. Looking forward to learning from you. Thanks.
Thank you. So good afternoon and assalamu alaikum, everyone. Thank you very much for having me here. So I shall be presenting the results of a phase 3 trial looking at the effect of preoperative breast MRI staging on locoregional recurrence in early stage breast cancer. This was a study which was presented at the San Antonio Breast Cancer Symposium by 𝗦𝗫 𝗫𝗀 et al. I don't know. Yeah, sure. Okay, so yeah. So as we are all aware, so when it comes to breast MRI, it remains the cornerstone for breast lesion detection, especially in the setting of preoperative assessment when we are looking for disease foci apart from the index lesion. And it is commonly used in pre-surgical planning. And there are many studies which have consistently demonstrated that breast MRI is the gold standard when it comes to detecting obscure foci of disease. And in many cases, it actually upgrades the patient from one who would be amenable to breast conserving surgery to one who would require a mastectomy. But however, what we do not know is whether these extra foci of disease picked up on MRI and which are then subsequently treated with more aggressive surgery, does this actually translate to a better oncological outcome for the patient? And most of the studies which have been done to look at this are all retrospective in nature. One such trial was the breast MRI trial, which was undertaken by Mota et al. In 2023. So if you look at the graph over here, we can see that almost 99% of patients remained local recurrence free at a period of 5 years, whether they had an MRI or not prior to having surgery. However, what this table highlights is that majority of the patients who were looked at in this study had hormone receptor positive subtype of breast cancer. So that was about the prior trial. Now coming back to the current trial, the hypothesis of this trial was that the detection of any extra disease focus from MRI is more relevant, or it has a higher impact for ladies who have a more aggressive tumor type. And pre-operative MRI improves staging, specifically in hormone receptor negative, HER2 positive, and triple negative breast cancer cases, with the end result being a lower recurrence rate at 5 years. So this table demonstrates the eligibility criteria, and these were then sorted out into criteria which were undertaken at diagnosis versus after neoadjuvant chemotherapy. So basically, all the patients who were recruited into this trial had early stage T1 or T2 node negative tumors. These were all HER2 positive, hormone receptor negative, or triple negative breast cancers. None of these patients had any known germline BRCA1 or BRCA2 mutations. And after undergoing neoadjuvant chemotherapy, all of these patients had to be amenable to breast conservative surgery. And in those cases where there was multifocal disease, it had to be such that it could be incorporated into a single resection site. So this is just a flowchart demonstrating the pathway. So there was a 1:1 randomization of patients into a no breast MRI arm versus those who had a breast MRI arm. And those who had a breast MRI did so within 30 days of having had the mammogram. Now, obviously, the patients who did not have an MRI went straight to surgery. And in the patients who had an MRI scan prior to the surgery, there was then the decision-making process of whether they underwent breast-conserving surgery or they were upgraded to a mastectomy. And in all cases, the patients underwent surgery within 6 weeks from presentation. And at the bottom right corner of the screen, there are the primary and secondary endpoints, which I shall be discussing subsequently. Okay, now a bit about how MRI decides the management of breast cancer when we're talking about breast conservation or mastectomy. So in cases where MRI does pick up extra foci of disease apart from the index tumor, now if these additional foci are within 2 centimeters of the index tumor, then they could be incorporated into the same resection margin, and we did not need to sample them further. But however, if they were more than 2 centimeters away from the index tumor, then this warranted further assessment with a biopsy. And in all cases where patients were upgraded to a mastectomy because MRI detected multifocal disease, in those cases, all of these additional foci necessitated a biopsy as well. So statistics, this was a superiority trial with a power of 80%. The sample size was 317 patients who were randomized between 2014 to 2019 across various academic and community centers. And the assumptions were that there would be a 5-year local recurrence rate of at least 10% in the no MRI arm, and there had to be a detectable difference of at least 8% decrease in the local recurrence rate in those who underwent an MRI before surgery. So this is the consort diagram of the trial. A total of 161 patients were allocated to the MRI arm versus 158 patients to the no MRI arm. As we can see over here, quite a few patients opted out of the study before surgery, and a few more patients opted out of the trial during follow-up. However, the number which was analyzed remained the same across both arms. So these are the demographics and clinical characteristics. So the mean age of the patients who were recruited into the MRI arm was around 60 years, versus no MRI arm was 60 years, apologies. And those who were recruited into the MRI arm were 57.4 years. And as I mentioned earlier, majority of these patients had low stage T1 node negative cancer. Most of these were HER2 positive. So the HER2 positive rate for both arms was comparable at 19.6 versus 19.9%. Almost all of these cases had an ultrasound performed at the point of diagnosis, which confirmed solitary or unifocal disease. And the number of patients who underwent systemic chemotherapy was sort of comparable at 83.5% for the no MRI arm and 87% for the MRI arm. And 15.8% of the patients from the no MRI arm went on to have neoadjuvant chemotherapy versus 19.3% for the MRI arm. So it's understandable that the MRI arm had a slightly higher proportion of patients undergoing neoadjuvant radiotherapy, and that's presumably because they had multifocal disease. And when we look at the local regional treatment, majority of the patients underwent breast-conserving surgery in both arms. And most of them had sentinel lymph node biopsy, although the proportion of patients having sentinel lymph node biopsy was lower in the MRI arm. The number of patients who had a positive tumor margin after surgery is comparable at 6.6 and 6.8% for both arms. And again, the percentage of patients who underwent adjuvant radiotherapy is also comparable at 85%. Okay, and moving on to endpoints. So the local recurrence-free survival rate at 5 years was comparable for both the MRI and non-MRI arm. So the non-MRI arm had a recurrence-free survival rate of 95.7%, and the MRI arm had a recurrence-free survival rate of 93%. So this was not deemed to be statistically significant by the authors. And then if you look at the secondary endpoint amongst the cohort of patients who had breast conservation surgery, again, this was comparable at 95.4% for those who underwent MRI versus 94% for those who did not, those who had an MRI. And then if you look at the distant recurrence-free survival rate at a 5-year period, there was no difference with an overall distant recurrence-free survival rate of 94.3% for both arms of the patients, those who had an MRI and those who didn't have an MRI prior to surgery. And there was no difference between the overall survival rate either at 92.2%. So we can see the trend over here that there's not much of a difference. And then if you look at the exploratory endpoints, so if we divide both cohorts by the tumor subtype, so those who had a hormone receptor negative but HER2 positive tumor type, I think the local recurrence-free survival rate was almost similar between 90 and 100%, with absolutely no difference, as we can see, between patients from both arms. And if you look at the triple negative tumor subtype, again, they didn't, both arms, whether they had an MRI or whether they didn't have an MRI, they didn't do massively different either. And if you look at the local regional recurrence rate at 5 years, based on the age group of the patient, for those who are under the age of 50%, there were almost no recurrences recorded at a 5-year period from surgery in those who did not have an MRI. And for those who did have a pre-surgical MRI, the recurrence rate was between 90 to 100%. So in conclusion, I think what this trial shows is overall the 5-year local regional recurrence rate for triple negative and hormone receptor positive, hormone receptor negative, HER2 positive patients is very, very low. And pre-surgical disease assessment MRI before operation does not really translate to improved oncological outcomes. And there is no indication of MRI being beneficial based on different tumor subtypes or different age groups. And it may well be that, the extra foci of disease which are picked up on a pre-surgical MRI scan of the breast are adequately treated by chemotherapy and radiotherapy. And in fact, extrasurgical resection or upgrading to mastectomy doesn't really make a difference for these patients. And we also have to remember that mammography and ultrasound, being the conventional imaging modalities, have been around for quite a few decades now, and they have evolved and advanced, and we are getting better at picking up multifocal disease using conventional modalities, and MRI may not have really added much. So the routine use of preoperative breast MRI does not really improve the oncological outcomes of hormone receptor negative patients. And the subset of patients are undergoing additional analysis looking at the re-excision rates of these tumors and also the contralateral breast cancer rates. So this is still an ongoing analysis. Okay, that's all. That brings me to the end. Thank you very much.
Thank you so much. Great talk. Lots of questions. So it's given me great pleasure to introduce Dr. 𝗦𝗫𝗫𝗀. Dr. 𝗦𝗫 is a very accomplished oncologist working with us at Burj Cancer Institute in Abu Dhabi. She's subspecializing in breast as well, and she's a patient's advocate. She'll be updating us more about interesting abstracts from San Antonio. Thank you, Dr. 𝗦𝗫.
Thank you so much. Assalamu alaikum. Thank you for the organizing committee. Thank you, Dr. Aida, for allowing me to present today. And I hope you have a very interesting talk. So I will be presenting today a single-arm confirmatory trial regarding tamoxifen monotherapy for low-grade DCIS in a Japanese trial. It was conducted in one of the Japan Clinical Oncology Cancer Institute, and it's called 𝗬𝗦𝗃 trial. So let's dive in. Not working. Sorry. So this is the disclosure of the presenter. So to background, the frequency of DCI is currently increasing, and we know this is because of the screening program have become more accomplished in the recent years, and the standard treatment of DCIs so far is surgical resection with partial mastectomy followed by radiation, and this is the standard of care, has not changed throughout the years. Now, we have a real-world data showing that no surgery treatment for low-risk DCIs did not change the prognosis. And as well, we know that 2 years ago, there was a phase 3 trial, which is a COMET trial, investigated the role of only observation for low-risk DCIS, had a positive trend, but unfortunately, due to the shorter duration of observation, this trial never had a significant outcome, and it was omitted. So far, just only surgery for patient low risk. Now, coming to the trial of today. It's having a problem. Yeah. So the inclusion criteria included all ladies more than 40-year-old newly diagnosed with DCIS, had to have unilateral breast cancer, and the low-risk DCIS was defined as nuclear grade 1 or 2 without community necrosis, and it has to be by the local pathologist confirmation. ER positivity was allowed to be more than 10% and without HER2 negativity. And tumor size, most important to highlight, did not exceed 2.5 centimeter in the trial, and it was confirmed through imaging, mammogram, ultrasound, and MRI. Now, regarding the sample size, it has to be sufficient either through vacuum-assisted biopsy or through ultrasound-guided biopsy. Now, coming to the definition that had identified choroidal necrosis was defined as solid intraepithelial neoplasia at the basement membrane with a central zone necrosis. And just keep in mind the necrosis that's seen in the intraductal spread of the carcinoma with a micropapillary or cribriform butter was not identified as choroidal necrosis, and those patients were allowed. Nuclear grade was evaluated based on 3 elements: size, appearance, and feature. Nuclear grade of 3 were excluded, so only nuclear grade 1 or 2. Coming to the trial optimization, they had a safety assessment at 5 years. In the first 6 months, it was 3 monthly, and in the efficacy, it was a 10-year. The first 1 year, it was 6 monthly. Thereafter, it was 6 monthly. Patients were followed closely, and if any patient developed any sign of increasing in size or ultrasound or imaging characteristic invasive, they had to have a biopsy confirmation, and if that happened, they had to have surgery. All of the patients received tamoxifen with 20 milligram per day for a total of 5 years. Coming to the primary endpoint was a 5-year cumulative incidence of ipsilateral invasive breast cancer. Secondary endpoint were ipsilateral breast cancer free survival, contralateral breast cancer free survival, overall survival, and surgical proportion and timing, as well as safety, were studied. There was 2 protocol amendments to highlight. First protocol amendment was on 29th May 2019, and the age limit was cut off, and most of the patients had enrolled, and the tumor size by MRI were removed. The second amendment, that any cases without calcification were allowed. Now, coming to the statistical power, the study analyzed to have a power of a 5-year identification of cumulative incidence of ipsilateral breast cancer at 7%. So translating that to a patient have to have only 7% cumulative incidence of breast cancer. And this translates that if only 14 cases or low develop ipsilateral breast cancer, this null hypothesis will be rejected. But unfortunately, we know that 18 patients actually developed ipsilateral breast cancer. Hence, there was an early termination by the data and safety management, and the trial were omitted in June 2025. This is a patient disposition. Total of 344 patients were included. There was 3 consents withdrawal at the beginning, and a total of 337 patients were eligible. Median follow-up was 36 months. The enrollment were from July 2017 till Jan 2024, and the data cutoff was December. And as we explained earlier, the removal of the trial, and it was discontinued in June 2025. So patient characteristic, we can see here clearly that around median age was 53 years. Nuclear grade, most of the patient, around 68% had a nuclear grade of 1. Menopausal status was well balanced 48 in the premenopausal and post 51. ER, as we mentioned, all patients had to have ER positive 100%, and most of the patient had progesterone positive of 92%. Just to keep in mind, the tumor size, where if you can see all of the tumor size through the mammogram, ultrasound, and MRI were actually less than 2 centimeter cutoff. And coming to the primary endpoint. So at 5 years, we can see around 18 patients developed invasive ipsilateral breast cancer, and this is translated to a cumulative incidence of 9.8, which increased the predefined specified subset of 7% at 5 years, and this is the primary endpoint not met, so the study is negative, unfortunately. Now, coming to the subgroup analysis, we can see clearly that the tumor diameter, imaging defined tumor diameter more than 2 centimeters, have a significant risk of developing breast cancer with a significant p-value of 0.27 at the mammogram, and as well 0.4 at ultrasound and MRI. Regarding other factor, age, nuclear grade, and progesterone and calcification, none of them had any significance to be associated with invasive, only the tumor size more than 2 centimeters. Secondary endpoint at 5 years, we can see that overall survival was 98.8%, and at 5 years, contralateral breast cancer free survival around 97.5%. To highlight, they had 4 events, 2 of them were invasive and other 2 without invasive cancer. Coming to the secondary endpoint investigating the ipsilateral breast cancer-free survival at 5 years, we can see it is around 89.7%, and the surgery-free survival at 5 years was 82%, and this is around 32 patients developed between invasive and non-invasive cancer. Safety were observed around, I believe, very few patients developed grade 3 event, and this is mainly at the ALT and AST. We know this is in clinical scenarios. Only 2.1 developed grade 3 AST elevation, and only 2.7 developed ALT-related elevation. And around the discontinuation rate of tamoxifen was around 26 patients due to the adverse event. So to summarize, this is a 5-year cumulative incidence of invasive cancer following tamoxifen monotherapy without surgery was a negative trial of cumulative incidence of 9.8 at 5 years. The invasive cancer have developed over time, and this is also highlight the need for longer term follow-up for those patients. The extent of non-invasive cancer, 2 centimeters or larger, is the most high risk factor that determine the development of invasive cancer. There were no breast cancer deaths, and contralateral breast cancer was just only 1.2%, which is still low number. Adverse event primarily included hormone-related adverse event, and usually impaired liver function were the most common, but usually manageable in the clinical setting. To conclude, LORETA trial, which pre-specified 5-year cumulative incidence of ipsilateral invasive cancer, was a negative trial. However, the investigator concluded in a carefully selected cases, such as those with very small non-invasive cancer without treatment with tamoxifen monotherapy without surgery, still might be a viable option for low-risk DCIS for ER positive, HER2 negative. Thank you so much for your time.
Thank you so much. We'll ask maybe the speakers to come over to get questions. I think we need one more chair. I'll go moderate from there.
We need 2 more chairs.
I'm pretty sure there's plenty of questions.
Before we start the questions, wait. Don't. I know. We will give you room too.
بالعكس حلوة. It's a very nice group.
Are you traveling?
So just for how much time do we have for questions, Dr. Aida, for this? 10 minutes? 5 minutes.
Okay, let's start then until they bring them more chairs. So we start? Yeah, we need more. One more chair.
لا خلاص. No, that's it. That's it. I'll stay standing. It's fine. Okay, so
shall I start with
Dr. Of course.
With Dr. Rita? I mean, this is your presentation and Dr. Sangeeta. I think these are the 2 presentations that is the hot topic every day in the tumor board. Yeah, and this is node negative changing to node positive changing to node negative. I don't know, it's just like that because there are many factors involved in that. Number of lymph nodes, size of lymph nodes, extracapsular extension, triple negative, triple positive. So tomorrow you have a patient, are you going to decide on which one you give radiotherapy or which one you don't give radiotherapy to? Because until now, node positive changing to node negative is radiotherapy is mandatory according to NCCN guidelines. And that's what everybody discuss and say, NCCN guidelines say that. And I tell them, Dr. Hassan says no. To that, according to this study.
I was gonna ask the question back to you. This was my question, preparing the question for the radiotherapist, because it is truly very challenging, like N positive, clinical N positive, and then going de-escalating after neoadjuvant chemotherapy. So where we do classify those patients in matter of regional treatment. So definitely in the study they had mentioned, this is a 3-year follow-up. They mentioned that we have to be careful about the original. There was no difference in matter of T size. There was no matter in the matter of the burden lymph node, but they didn't like specify more in details the biological subtype. Now, definitely we have to be careful. In my opinion, waiting further to see more about the outcome. Now, the purpose in the AXANA study was the local recurrence. They mentioned about the local recurrence, but as you can see, there was a big variety of the regional radiotherapy. So in my opinion, I would stick personally with the guidelines, even if I have to fight with Dr. Hassan. I think we need to stick with the guidelines in matter on how to treat the patient. I wouldn't be maybe comfortable omitting everything at the same time. Now, definitely we have the systemic treatment that is doing a big part of the job to protect the patients, but omitting everything at the same time, I wouldn't be comfortable. Now, I was just surprised on the variability of the radiotherapy. Like those were in 26 countries, in many institutions, and the treatment, like applying radiotherapy after the auxiliary management, was really very, very different. So you were mentioning guidelines, but I was very shocked that there was a lot of variety in how they treat regionally the radiotherapy in all those countries, in spite of the guidelines. Hassan, maybe you have a comment.
Not everybody follows guidelines. When they
So-
have the chance, they do. Dr. Sangeeta, what do you think? What's your take on that?
Thanks, Dr. Falla. I would agree. I mean, it's a little bit uncomfortable to omit everything at the same time when there isn't the data or the mature data to support it yet. So that would be my stance as well. One at a time till we get more mature data. And I have to agree. I was quite interested to see that as well, because quite a lot of patients were treated outside of what we would currently call guidelines, what are standard guidelines. So a variability in practice is quite interesting. But even in the one that I presented,
with nothing like no clearance, no radiotherapy, only maybe the systemic therapy. This was a little bit concerning to me.
That's true.
So again, guidelines are
Actually, the most demand comes from the surgeon. That we want this patient treated by radiotherapy because sometimes you hesitate and say, okay, I take this or I take that. But surgeons are very sort of, demanding in this point.
It's an MDT, it's a multidisciplinary. It's not about surgeon, radiotherapists, or oncologists. It's a multidisciplinary
It's going to be
case.
I think it's going to be case by case. The
Dr.
guidelines
Hassan.
are there just to guide you, as the name is indicating. But, case by case, as you mentioned, MDT discussion, etc. My question to you, so what are we doing if you have neoadjuvant therapy and you did sentinel node and you still have, let's say, 1 out of 3 lymph nodes? Historically, you should do dissection, but we are seeing more and more data that maybe we don't need the full dissection. And again, where would you add radiotherapy? So are you doing auxiliary dissection on any positive node post neoadjuvant?
So this is also the trial that I presented, although it shows that you should, but I don't complete axillary lymph node clearance since the Z11 was published. There's also the CENOMAC trial afterwards with much higher numbers than the second randomization of the ENZIMA trial.
Can I?
For 1, 2, 3, we definitely discuss all together. And
talking post neoadjuvant. He's talking post neoadjuvant.
Yes,
post
but post neoadjuvant, and we discuss definitely together in the MDT, and we discuss with the patient. Is a patient-centered care, and if it's only like 1 to 2, definitely after discussion of the guidelines is. But as you mentioned, like we have to be careful with the applying the guidelines, but with the centered care and discussion with the patient.
We have ongoing trial, I think, to that end, so we will have more answers to that.
Can I?
About this, especially, they
Dr.
don't
Salah.
give you an option. Yeah, they
I
don't
just
give you
want
an
to say
option.
something different.
Dr.
That
Rahim.
post-neoadjuvant, I would complete axillary lymph node clearance. Yeah.
So can I? We have a question here, and then we can open also rounds for questions. So Dr. Zainab, please. That was a question. Go ahead. Let's turn on the mic. We can.
The microphone, Dr. Dr. Zainab, your microphone is not.
So in case of a clinically positive and YPN positive, we usually look like the literature is suggesting looking to the baseline burden of lymph node. Like if 1 to 4 positive lymph node in the baseline and is still positive after neoadjuvant, still we can omit complete axillary dissection provided that we give radiation therapy. And this is also in the interim analysis. While if heavily involved lymph nodes, no, we have to go and dissect.
Well, post-neoadjuvant, I will argue we don't have a randomized trial to answer that.
It's happening. It's happening.
Yeah, it's happening. That's what.
It's happening. It's ongoing. Yeah.
Can I? So as a radiation oncologist, I'll answer this, and I think Dr. Sangeeta also. I'd love to hear, and Dr. Thuraya. So in our practice, we know that radiation works very well for microscopic disease. There is no question that radiation in the upfront setting, at least from the 𝗕11, the Emirates, we know that radiation can control microscopic disease. Now I'm going to go some question about the eczema because it's tightly concerning. But in the post-neoadjuvant setting, as of now, the Alliance trial is not published, so we don't know. So we're extrapolating. So just for everyone who don't, the Alliance trial is exactly like Emirates, but post-neoadjuvant setting, right? So, so right now we don't have. So in our practice, in our MDTs, exactly as Dr. Zainab looked, we looked at the initial baseline. If there was a lot of potential burden disease, we would tend to ask the surgeon to complete dissection. But if there was just a 1 or 2 suspicious lymph node post-neoadjuvant, let's say this is an ER/PR positive, but high grade, young patient, we proceeded with neoadjuvant therapy to try to do breast conserving surgery. The lymph nodes are still positive, but microscopically, we trust our surgeons. So our surgeons usually they do, and Dr. Fria is here, they do a complete assessment intraoperatively. If they don't feel anything gross, they leave it. Some centers, they do frozen section during the sentinel lymph node, and if it's positive, immediately they do complete. But we know that sometimes there's discrepancy between the frozen section and the final pathology. But I wanted to ask Dr. Sangeeta and maybe Dr. Thuraya, are you guys comfortable doing a comprehensive radiation with the complete, proper axillary radiation in those patients which we think there is residual microscopic, not macroscopic, microscopic disease, post-neoadjuvant therapy in the absence, as to Dr. Marianne's point, there is no current trial to prove that we can do this. But are you doing it in daily practice?
Yeah, I agree with you, Dr. Ibrahim. So I face this sometimes at the clinic where the surgeon calls me, there is lymph node positive, sentinel lymph node positive post-surgery, and the patient actually doesn't want to go for axillary lymph node dissection. So what to do? So I go back also and I ask what is the hormone receptor status. So I don't advise that if it's triple negative, grade 3, I don't advise, advocate more for the axillary lymph node dissection. However, if the patient is still refusing, then I would cover the axilla 1, 2, 3 and the supraclavicular lymph node, and also accordingly the IMN. But I know there is no evidence, but we can extrapolate from the other trials, which is like the the pre-operative.
Dr. Sangeeta, Dr. Falah as well.
For patients, with the modern mammograms and ultrasound machines, we see more and more lesions in the breast, especially here we have large breasts, heavy, so you see suspicion. So MRI become a standard even for, and most of the time we find other lesions in the same breast or in the other breast. Now this is causing a problem because it delays treatment of the patient, but you want to get the facts really right so you can plan how you treat the patient. So what's your experience in that?
So is that
sorry.
Dr. Hania, it's yours.
So yeah, so what I would have to say is I think it's a small sample size. So there are a few limitations of the trial that, so if you look at it, majority of the cancers were node negative. More than 90% were node negative, which is why we need to have an MDT discussion, because from my practice in the UAE, what I've seen is most cancers at the time of presentation tend to be quite widespread, and they are node positive. They are of a higher grade with high HER2 amplification. So I think it has to be a case-by-case discussion. There's no one-size-fits-all criteria. So we have to be a bit judicious about not applying it as a blanket rule that we do not need to do preoperative MRI. And the other limitation of the trial was that it recruited older patients. What we tend to see over here is that patients who present to us tend to be younger and younger, and they also have dense breasts. So breast density is a known independent risk factor when it comes to breast cancer. So again, MRI is of great benefit over here, but I think it has to be the entire team of radiologists, surgeons, medical oncologists, radiation oncologists, pathologists who sit together and make a case-by-case decision.
Can I please add to that? I think the traditional selection for MRI is ductal subtype, fatty breast, for example, doesn't need an MRI prior to surgery, but lobular subtype and Bioradz's density score C or D definitely would still benefit from MRI.
Also, sorry to interrupt, but it also depends upon the tumor type that we see. So for example, infiltrative disease pattern where we don't see a very well-defined lesion on conventional imaging such as mammography or ultrasound, we might need to go ahead and evaluate it further with an MRI because we might be under-assessing the disease extent, which is why regardless of the tumor subtype, there are a few cases where we are warranted to do an MRI.
But unfortunately, what's happening, almost 100%, I would say, are getting MRI, necessary or unnecessary, which is increasing the mastectomy rate, and we have a high mastectomy rate. When JCI comes, etc., they look at your mastectomy rate as one of the criteria. So here we are ending up, and we have the data that if you do more MRI, you are going to end up with more mastectomy.
But these days, multifocal, multicentric, I would like to remind, is not a definitive
not
indication anymore for a mastectomy. You still can do breast conserving surgery and oncoplastic with
And
oncoplastic.
they feel they are more protective. Like if we do all the kind of investigation, we are more protected for. What about the contrast mammogram? When are you replacing the MRI with your contrast mammogram?
So contrast enhanced mammography is quite beneficial, specifically for, in terms of, in breast cancer screening, I would say. It's known to have equal sensitivity and specificity as opposed to, like if you compare it with MRI. But however, when we're looking at neoadjuvant chemotherapy follow-up for breast cancer, I think MRI is still the gold standard. Some centers have been using contrast-enhanced mammography, but there's limited data really. There are a few trials looking at it, and I think we just have to watch this space. And it would be quite easy because it doesn't take as long as an MRI, but that is obviously a thought.
I have a question just regarding the other abstract, just to move slightly, because Dr. Thoraya presenting a very mind-intriguing thoughts, which I think is underutilized, which is neoadjuvant radiotherapy, which is giving SBRT dose kind of to the tumor, then giving neoadjuvant systemic therapy, and then assessing the response in the lymph nodes, which is a very and seeing the T-cell infiltration. So moving into the neoadjuvant setting, and maybe Dr. 𝗦𝗺 also from your experience, the medical oncologist in the setting of pembrolizumab as well, and the excellent response. So where do you see this happening? Is it only in the clinical trial? When do we start pushing the envelope and start thinking, okay, when do I, because 3 fractions over 1 week, it will not delay anything in terms of systemic therapy. There is no safety concerns of giving SBRT with pembrolizumab. So, and we see that the T-cell infiltration is much higher in the lymph nodes in the setting of giving a higher dose. So what's next? Is it happening in the more and more prospective manner? Should we consider opening a trial here where we can involve other centers? Are you doing any neoadjuvant treatment in your center in Muscat, or anyone has any experience of neoadjuvant radiation treatment? So just want to open this topic before we wrap up. Dr. 𝗦𝗺.
I think currently the field is moving quickly, and we have already multiple data showing that TILs are having very high utilization to see how is the PCR. And it is a mind and thought-provoking whether giving neoadjuvant radiation therapy will increase those TILs and hence the PCR. But currently the clinical practice, I think this is only clinical trial. I think maybe in the future, but I will not push for it in the maybe coming years. But I believe TILs are coming, and the way is paving for the triple-negative treatment. But so far, I will hold my tight for the same neoadjuvant treatment protocol.
Yeah, so same here. We don't advocate for currently for the neoadjuvant radiation, but I think this trial is interesting because we can also, for example, in the Pacific trial for lung cancer, we know the benefit of adjuvant immunotherapy, durvalumab, post-concurrent chemoradiation, and how the immunotherapy can increase like the amount of pathological complete response. Also, for example, in the rectal cancer with the TNT is now the standard of care. So maybe in future with similar studies, we can prove that TNT in breast cancer is as beneficial as in the rectal cancer.
Actually, ask because I want to go back to the eczema trial.
Just to
last
the
one.
same. So in that study, these are ER positive disease. What we know from metastatic setting, that two factors predict response to immunotherapy. The degree of ER positivity, meaning the lower your ER, the more responsive you are going to be to pembro. And also, so luminal, again, luminal B, which is what the study I think showed. But the PD-L1 expression was very predictive also. So I don't think they looked at any of these in this trial. So that you have to be really
Which patients?
Exactly. Not all ER positive are going to be beneficial.
Actually, in this trial, they were looking for the T cell infiltration and the PDL expression. So they found that in the non-luminal A, it is more T cell infiltration and higher PDL expression, and those the patients who benefited from the preoperative radiotherapy to have pathological complete response.
Then just last question from my end, at least, because of the time, Dr. Rian, Dr. Sangeeta, you presented very controversial data. We are in the era of de-escalation. Everyone's pushing for de-escalation. Suddenly, you're showing me a study that de-escalation, which is the basic thing between sentinel and axillary, in the upfront setting, did not meet its primary endpoint. Yet you mentioned that we have two other trials. So what do we do? What do you take out of this?
Again, personally, I don't think this should change our practice. We've been in this de-escalation era for a few years now. And I mentioned the limitations of this trial, that the recruitment was much less than expected. So I think we have to wait for more results. Personally, I would not complete axillary lymph node clearance if I had 1 out of 3 lymph nodes on a sentinel lymph node biopsy where the patient has fits all the criteria, T2, clinically node negative. Again, there are cases that should be discussed case by case. If you have a young patient with aggressive disease, triple negative or HER2 positive with 3 out of 3 positive lymph nodes, then it's a different case. But with the straightforward cases, I would not adopt the results of the...
Dr. Sangeeta, would you send your patients back to the surgeon or would you irradiate?
You mean if they... After a positive node? I mean, most of the patients are well worked up nowadays. And if you are very confident you've done the workup properly and you had a clinical node negative to start with, there is enough evidence if it's 1 or 2 nodes, even from the Z11, that you don't benefit from completion axillary dissection. This is quite controversial, yes, and
the workup is also controversial because I remind you that in the Z11, they didn't even have an axillary ultrasound. Clinical was palpation, clinical.
True.
Now there is another factor entering the scene is PET-CT, because PET-CT shows you a lot of positive lymph nodes when it's clearly negative, and shows more than 1, 2, 3, and different levels, and IMC sometimes.
We don't do PET scan. We don't do PET-CT regularly.
We do
for all
PET-CT
patients.
scan for almost every single.
We don't.
No. Generally speaking, not only for the axilla, we do it as a part of the staging, especially for
T2 clinically N0.
Some people do that. And you get surprises. But I'm saying this is not the standard. But like this MRI, we do MRI for everybody. But it's not. But we see that in the clinic, and that's what maybe Dr. Hassan.
No, I agree. I see patients, they are already seen by the surgeons or whoever And they come to me with MRI, PET scan, oncotype even.
No, please, not all surgeons.
Some surgeons. So unfortunately, but I agree. Stage 1 luminal A, absolutely, they don't need PET scan, but it is done, unfortunately.
The problem, some patient gets mastectomy and then they get PET CT scan and they found lymph nodes.
Yes.
Okay.
So
again,
Ibrahim, one point. So if you have done axillary dissection after neoadjuvant and you have 1 or 2 nodes positive, do you radiate?
Ask the radiation. I would, but ask them.
Depends on the level of the dissection. So usually they are the surgeon doing is level 1 and 2. So according to the burden of the disease, and also the ratio of the positive lymph node to the lymph nodes excised. So if the ratio is high of the positive lymph nodes, and I will usually radiate the whole area, also including the IMN. But if the ratio is less, I will just cover the areas that is not dissected, for example, level 3 and a supraclav.
100%.
And the IMN depends on like multifactorial reasons.
Okay, I think for the sake of time, we got to conclude this session. Thank you so much for being with us, everyone. Thank you to the speakers. Just a picture.
أنا من العراق من بطنة. احنا زمان ما كان عندنا خطوط بالعراق إلا عائلة أو عائلة ثانية. بس هسه كل الناس صارت المصيبة الطبيب بالشيعة وبالسنة وبالمسيحيين لا في شيعة زاهد
So we thank you so much for being with us. It's a lunch break, and we will be back at 2:10 to resume the rest of the sessions. Thank you so much.